would request Dr. Sunanda Kulkarni, Dr. Malini KV, Dr. Mangala Ramchandra, Dr. Mohini Jadwani, and Dr. Suman Rao to kindly come. Please help us light the lamp and have a wonderful beginning to this program. Thank you so much. I now invite Dr. Srinath Manikanti, Senior Consultant and my dear colleague, to formally give you all an introduction to this program.
Thank you, Dr. Tejal. Thank you, Dr. Tejal. So thank you everyone for sparing your valuable time on Sunday morning. And once again, warm welcome to all of you to this symposium on fetal growth restriction. Over the last decade, there is a significant improvement in the neonatal outcomes in India. That is mainly because of evolving fetal medicine department, and so better obstetric care and definitely better neonatal care. So all these three departments come together to give best outcomes for these vulnerable babies. So why this symposium on FGR? Because FGR is a major problem in India. Almost 1/4 of every, 25% of every, most of the pregnancies are complicated by fetal growth restriction. And majority of these FGR babies are also small for gestational age, and they come with their own morbidity and mortality. And we need a good collaboration between all these three departments of fetal medicine, obs and gynae, and neonatology. And at Mount Kaveri, we are fortunate to have fantastic fetal medicine team and a fantastic obstetric team which supports our neonatal team. And we thought probably bringing all these three fields together and sharing experience will be a right thing forward. And insults can happen to the fetal growth either early in the pregnancy or later in the pregnancy, and how it matters. Dr. Chitra Ganesh is going to give an elaborate talk on that. And why SJ is a concern is because almost half of the stillbirths happen in SJ babies, and also 72% of the unexplained fetal deaths are actually SJAs. And it impacts the fetal growth and it has adverse perinatal outcomes. Majority of them can be stillbirth, and abnormal long-term neurodevelopmental outcomes in earlier infancy and childhood. And not only that, it can have long-term implications even when these babies grow up as adults, having metabolic syndrome and behavioral issues. So there's a significant problem that we need to address together with all the three departments coming together. So there are different factors affecting the fetal growth. So fetal, placental, and maternal to discuss in detail. So we have a fantastic program, and to start with, we'll have a very entertaining and informative talk on fetal growth restriction, diagnosis and surveillance by Head of the Department of Fetal Medicine, Dr. Chitra Ganesh, who is actually a pillar behind this symposium. And you can say that she's a brain behind this symposium. And following that, we have how to recognize this postnatal recognition of FGR by our own colleague, Dr. Soumya. And follow that with another experience. We had a fairly new unit, and Dr. Bhaskar will share our experience of dealing with these FGR babies and the outcomes. And after that, we'll have two stimulating talks from Dr. Deepthi and Dr. Tejal. They both will try to connect the dots between antenatal findings and neonatal implications of that. And follow that, we have a very star-studded expert panel discussion on the fetal growth restriction. We have eminent panelists from both obs-gynae and neonatology, and you'll all have a academic feast. Wish you entertaining next 2.5 hours. With that, I would invite Dr. Chitra Ganesh to start. To start a talk. Thank you.
A very warm good morning to all of you. The Department of Perinatology came into existence in Ma Kaveri about probably 8-10 months ago. We were working as independent units. We had our obstetric gynec attached along with our multi-speciality hospital. Then the fetal medicine came in. So once we found out that we have the background of a multi-speciality, that means we have a good cardiology, neurology, pediatrics, and pediatric surgeons. So we thought this is the ideal time to bring them all together under one banner of perinatology. The Department of Perinatology of Ma Kaveri is associated with Dr. Suresh and his Mediscan team for all other fetal intervention procedures. And they have been our mentors so far. We have already conducted, in a span of 2 weeks, we have done 2 IUTs and both the babies intrauterine transfusions for fetal anemia, and both these babies are doing good so far. So when we delivered babies, which were about 600 grams, 700 grams, and following up during the antenatal period from the fetal medicine department and handing it over to the neonatologist, and after that forgetting what's happening to them, but we are more worried about the existing cases, then suddenly one fine day Dr. Srinath posted in the group that this baby, which was 625 grams, is going home hale and healthy, and the current weight is this much. Then that is when it struck to us, yes, the team is working behind, and it is high time that we come forward and put our data in front of the other esteemed consultants who have their own experiences to share. So we start with what is fetal growth restriction, the diagnosis and surveillance. Fetal growth is the result of the maternal availability of nutrients, placental transfer, and of course the fetus' own growth potential. And every fetus has its own growth potential, and that is the most important thing one needs to understand, because this is where you differentiate normal small babies from pathological small babies. And the failure to achieve this endorsed growth potential is what is defined as fetal growth restriction. And the diagnosis of fetal smallness, how do we define or how do we quantitative, is to assess the fetal weight or the abdominal circumference, which is less than the 10th centile for the period of gestation. So when we say small for gestational age, this is basically a statistical definition. Any fetus which is less than 10th centile is defined as small for gestation. And this group itself can include normal small fetus as well as fetuses which are small and also growth restricted. So the normal small fetus or the constitutionally small fetus, one look at the graph is enough for you to say that this baby started in the low growth percentile, but you see it is maintaining the growth graph parallel to the normal graphs. That means this baby is small but is very happy inside. There is no placental pathology involved. There is no fetal adaptation because there is no hypoxia at all this baby is experiencing, and therefore there is no Doppler changes and the normal perinatal outcome. On the other hand, this baby which started in a 50th percentile and above suddenly finds itself going down, and this look at the graph is enough for us to tell this is a pathologically growth restricted fetus. That is because there is an abnormal placentation, there is hypoxia, and the baby is adapting itself, and intrauterine adaptation is still to a certain level, after which the baby is not able to adapt, and that is when you identify and deliver. And these pregnancies invariably are associated with preeclampsia, and they have poorer perinatal outcome. So the main tools when you want to diagnose fetal growth restriction starts with the dating of pregnancy. Therefore, it is very important that we have a good dating scan done, a good CRL taken, magnified, measured appropriately, so you know the gestational age of the fetus, which has to be assigned as early as 8 to 9 weeks of gestation. Once you know the age of the baby, your next visit, or when the patient comes to you for the second trimester, it is basically measuring the baby, which means you are measuring from the head to foot. You include all the basic biometric parameters, BPD, HC, AC, and FL, and not only measuring them, but also finding out what percentile those measurements fall for that period of gestation. And once you get those measurements, it is important that we plot them on a graph. So any 2 visits by a patient where you do the measurements, biometric measurements, it is important that we plot them on the graph. And fourth, of course, is the Doppler assessment. Doppler assessment is the flow which goes to the baby. We have 2 types. One is the maternal compartment and then is the fetal compartment. We use uterine artery Doppler for assessing the maternal compartment, the placental resistance, and the umbilical artery Doppler to find out how much the fetus is getting, and the MCA Doppler to find out whether the baby is adapting itself by redistributing its flow, and ductus venosus to show whether the fetal heart is normal or not. So all these are included in your fetal Doppler studies. And just like biometry, Doppler parameters have also to be plotted, because the trend in the Doppler parameters is one thing which helps you to during your surveillance and in the management of the growth restricted fetus. The clinical relevance of fetal growth restriction itself is to answer the 2 questions. When should I intervene? I have already diagnosed fetal growth restriction and I have my parameters in hand. Should I deliver now or can I wait? If I have to wait, how frequently should I have to see her? And there comes the fetal growth restriction types. The Barcelona study under Gratakos has now classified fetal growth restriction itself into 2 types. One is the early onset fetal growth restriction, which occurs before 32 weeks of gestation, and the late onset, which is manifested after 32 weeks of gestation. 32 is just an arbitrary number. 32 weeks onwards, if you diagnose a fetal growth restriction, it is the late onset. And both of these are distinct by their mode of onset, by the way how the disease progresses itself, the way the Doppler parameters present in the different types of growth restriction, as well as in the postnatal outcome. And in both, placenta is the determinant factor. Early onset growth restriction is seen in about 1 to 2% of pregnancies. It accounts for about 20 to 30% of all the FGR babies. The onset occurs either late in the first trimester or in the early second trimester. It can be due to placental as well as non-placental causes. There is massive placental dysfunction. That is, more than 30% of the placenta is affected in this type of growth restriction. And because the more placenta is affected, there is hypoxia, fetal adaptation, and therefore you have the cascade of Doppler changes, which is very pathognomic of early onset fetal growth restriction. Majority of them, because there is a placental abnormality, present with abnormal umbilical artery at diagnosis, and more than 50% of them are associated with preeclampsia. The late onset FGR, on the other hand, is diagnosed after 32 weeks. Here, the fetal hypoxia or hypoxemia is only secondary to placental insufficiency. There is no non-placental cause for late onset FGRs. An association of PE is very low in them. The placental disease here is mild. That means less than 30%. It can be 10%, 15% or 20% of the placenta which can be affected. Because the amount of placenta which is affected is very less, these fetuses are able to manage themselves to a certain stage of pregnancy, after which when the demand of a certain group of fetuses increases, even that small amount of placenta which is not available for them becomes important, and that is when they show growth restriction. The Doppler markers in them is not the umbilical, because there is enough placenta to which has supplied the baby, and therefore there is no basic hypoxia which affects the umbilical arterial flow. So late onset FGRs do not show umbilical artery changes. However, because of the hypoxia, these bigger babies respond to hypoxia by changes in the maternal MCA PI as well as in the cerebroplacental ratios. Half of these hypoxia can also be due to uterine artery constrictions, and therefore they have abnormal uterine artery Doppler. You have a baby which has a normal uterine artery during your first and the second trimester, suddenly becomes abnormal in your third trimester, that is, and also shows a downward trend in growth. That is when you start thinking about FGRs and putting them under surveillance. And this type of FGRs are far more prevalent than the early onset one, accounting for about 70 to 80% of the total growth restrictions. So the main differences between early onset and late onset is, the early onset is a management, because you are already diagnosing it much earlier, because there are changes in growth, changes in the umbilical arterial flow, whereas in the late onset, diagnosis becomes a problem, whereas management is easy because the baby has already reached a certain level of maturity, and therefore diagnosis, once you diagnose them, you know how to monitor them and when to deliver. And another important thing is, these early onset fetal growth restriction are immature fetuses, therefore they have high tolerance to hypoxia. They've already been in the intrauterine compartment with hypoxia, so they know how to adapt themselves, whereas these bigger babies, the ones with late onset FGRs, are the ones which are not exposed to hypoxia, and sudden hypoxia at 30 to 34 weeks becomes much more detrimental to them. So now, how do we critically diagnose these two conditions, that is with the Delphi consensus? All early onset FGRs, you need to have a solitary criteria. That means if these criteria are present even as a single parameter, these you can think of early onset FGRs. The first is a very small baby, where the estimated fetal weight or the AC is below the third percentile. The severe smallness itself classifies them as growth restriction. Umbilical artery PI, which is very high or absent end diastolic flow. That means your placental insufficiency has become too high. Any one of these criteria, even if present in isolation, calls for the diagnosis of an early onset FGR. Whereas the contributory criteria for the diagnosis of early onset is a small fetus, that is EFW or AC, which is less than 10 centile, combined with Doppler changes. It can either be an uterine artery PI, which is above the 95th centile, or an umbilical artery PI, which is above the 95th centile. So when any one, along with the smallness, with any one of the Doppler changes is present, then you diagnose early onset FGRs. The late onset FGR, as we had already seen, is not much of a placental insufficiency causing at that point, so you do not have umbilical Doppler changes. However, when the fetus is very small, the solitary criteria for diagnosing late onset after 32 weeks is a very small baby when the percentile grows below the third centile. Contributory criteria is a smallness in weight or the AC, along with one of the Doppler changes, either a uterine artery PI, which is above the 95th centile, or a CPR, that is a cerebroplacental ratio falling down, or when the growth shows a downward trend, that is, it falls below 2 quartiles, that means it becomes lesser by 50% of what we had seen earlier. Suppose the fetus, if we had measured it at 22 weeks, the estimated fetal weight or AC is above 60th or 80th percentile at that point. When suddenly it falls below the 50th percentile, it becomes 40th percentile or 35th percentile when it comes into the third trimester. Per se, it does not fit into the definition of smallness because the fetal weight is above the 10th centile, but definitely the trend has fallen down. This itself is another diagnostic criteria for late onset growth restriction. So, a fetal growth restriction can occur in a small for gestational age as well as in a fetal appropriate for gestational age babies. And in the small for gestational age, the criteria of too much of smallness, that is less than the third centile, along with Doppler changes, especially the umbilical artery Doppler, and in the appropriate for gestational age, when there is a downward trend in growth, along with MCA or CPR, these are the parameters which helps to diagnose and categorize them. So coming to the vessels, fetal Doppler vessels, which we normally use, you know, it is the uterine artery Doppler, umbilical, MCA, ductus venosus, and aortic isthmus. Studies on aortic isthmus are still going on, so as of now we do not include them into our protocol in all cases, whereas these are the vessels which we normally insunnate in the fetal Doppler. Coming to the Doppler indices, or relearning the Doppler in a different way from what we have been used to earlier, is to categorize them into diagnostic markers and prognostic markers. So we have certain Dopplers which play the role of diagnosing a condition and certain Dopplers which helps us to take the decision. That means the decision of delivering the fetus before 37 weeks, and that is a prognostic marker. The diagnostic markers helps in identifying fetal growth restriction from normal small for gestational age. As we know, we use umbilical artery for that. So it differentiates early, late onset as well as the appropriate for gestation or the small for gestational age fetuses. And prognostic markers helps us in delivering the fetus before 37 weeks of gestation. Coming to uterine artery, we know it is useful in assessing the maternal component of the compartment of the placenta, and the impaired trophoblastic reaction reinvasion results in decreased placental perfusion, and therefore it is reflected in the uterine artery PI, which normal uterine artery PI is high in the first trimester, and as the pregnancy advances it has to become low with more diastolic flow. But when this increases, that means placental resistance is increased. Therefore it is used as a screening tool to predict fetal growth restriction. It is also used, as I told earlier, as a diagnostic tool in detecting or diagnosing late onset FGRs. So uterine artery Doppler is a diagnostic marker. Next, coming to the umbilical artery. Umbilical artery is the fetal compartment. It shows how the fetoplacental circulation is going on. It is a surrogate marker of placental resistance, and it is used as a surveillance tool in FGR. In an early onset FGR, you are following the umbilical artery to find out how the placental resistance is increasing. Whereas it fails to identify mild placental disease and is normal in all cases of FGR. So when the placenta, more than 30% of placenta is affected, that is when you get a high resistance in the umbilical artery. When the percentage of placenta affection becomes more, as in 60% and above, it becomes absent, and 70 and above, it decreases, it becomes reversal. So it shows the progressiveness of your placental damage, and uterine artery, umbilical artery Doppler can be used both as diagnostic as well as prognostic marker. That is, decision to deliver sometimes is taken based on the reversal of umbilical artery in case of early onset FGRs. MCA is an important vessel which is the first one, highly sensitive to fetal hypoxia and starts showing changes whenever the fetus is exposed to hypoxia. And it is used to identify the brain sparing effect in case of early onset fetal growth restriction. Whereas cerebroplacental ratio, that is the ratio of the PI of MCA by the PI of umbilical artery, this is a most sensitive marker for hypoxia. MCA is very specific about hypoxia, whereas the earliest marker which shows changes in a late onset FGR is CPR. So it is important that we need to follow the trend in the cerebroplacental ratio also when you have identified or diagnosed a late onset FGR. CPR becomes a diagnostic marker. So once the CPR goes down and shows a downward trend, we know the progression of the problem, but we do not decide on delivering only based on the CPR. Ductus venosus assesses the cardiac status, and whenever the fetal has a right heart failure or a cardiac overload, that is when your ductus venosus starts showing changes. And increased resistance in the ductus shows that there is a low suspicion of acidosis, and when the right heart fails, then there is reversal, and that shows a high suspicion of acidosis. These are all very important because that is the point when you need to bring out the baby out. So ductus venosus becomes a prognosticating marker. It is no role in diagnosing fetal growth restriction, but it has a role on when to deliver. So once we have diagnosed and we have monitored, we diagnosed fetal growth restriction, we have to know how we are going to monitor it. That is from this landmark paper by Gratakos and his team of Barcelona. They have categorized the fetal growth restriction into stages, specifically based on certain parameters. So the severe smallness or a mild placental disease, that is when the estimated fetal weight is less than the third centile, or when any one of these Doppler parameters is abnormal, with a forward flow in your umbilical. Umbilical artery shows high resistance, but there is a forward flow. It falls under stage 1. It calls for a weekly monitoring, delivering at 37 weeks to 38 weeks, and induction of labor can be allowed. No need to take for section just because they are FGRs. When the placental insufficiency increases, when the forward flow ceases and becomes absent end diastolic flow or reversal, then it becomes a weekly monitoring and delivering them at 34 weeks, 32 to 34 weeks. And as the severity increases, this chart helps us to monitor. This has become very useful in our management of fetal growth restriction. We go blindly by this chart. We don't worry about the fact that the umbilical artery absent diastolic flow, because we have pulled on babies with absent diastolic flow for weeks together, 2 to 3 weeks also, before they become abnormals in order to catch up on the gestational age. Whenever preeclampsia sets in, when the mother has a preeclampsia, all these stages jump by one above, and management and monitoring becomes depending on that. So there are two-step approach once you start diagnosing a baby which is less than the 10th centile. First is to identify whether it is fetal growth restriction of, from an appropriate or an appropriate gestational or small for gestational age baby using a diagnostic Doppler index. The criteria used is when the estimated fetal weight is less than the 10th centile, yes, when the estimated fetal weight is less than the 10th centile, you use the umbilical artery Doppler to find out, to diagnose and then follow it up. In an early onset FGR, it is abnormal, whereas in a late onset FGR and SGA, the umbilical artery Doppler becomes normal. And second is use a prognostic Doppler as to when to deliver these babies. In an early onset FGR, the stress is on the heart, so it is the ductus venosus, you are going to follow it up and then use it for diagnosis, for delivering. Whereas in a late onset FGR, the stress is on the fetal brain, and this hypoxia, the small hypoxia which affects the brainstem, is seen by using your CTG and the biophysical profile, in which the most important is the breathing movements. These are the two centers which gets affected first by hypoxia, and so therefore it is important that you do the biophysical profile and CTG in all these patients. Daily fetal movements, it has been shown from studies that nearly 55% of women experience less fetal movements just before stillbirth. The majority of them, they preceded 3 to 4 days before actual IUD happened. There are no fixed number as to say that this many movements has to be there in this fetus. We cannot give them as a definite numbers, because each fetus has its own number. So it is important that you ask the mother how she was feeling before versus how she is feeling now. And if she comes for admission or comes with a complaint of 2 episodes of less fetal movements, it is important to put these mothers who have late onset FGR under surveillance and then treat appropriately. Coming to liquor, there is no role of liquor of amniotic fluid in our management or in the surveillance of growth restriction, because it's a very chronic marker. The moment the hypoxia is there for long, the renal supply is going to become less, and oligohydramnios has already set in, and the severity of progression of the disease does not affect your liquor, so liquor has no role in our surveillance or management. So to conclude, ultrasound and Doppler are the mainstay in the management of fetal growth restriction. The primary goal is to identify a small fetus based on its fetal weight, where the cutoff is taken as 10 centile. And once you diagnose the fetal growth restriction, it is important to distinguish whether it is an pathological FGR versus a small for gestational age baby, because of its implications on the follow-up intervals as well as in the timing of delivery. The third goal is to determine early onset versus late onset, and for which the following Dopplers, what was discussed, helps us in identifying or segregating them into the two groups. The fourth goal is in monitoring intervals and the timing of delivery, and for this you use that integrated protocol based on the fetal staging system, which has been put forward by the Gratakos and his team. So I invite all of you to our Society for Fetal Medicine. It's going to have a cardiac conference in the end of this month. We have international and national speakers talking on fetal cardia per se. The whole conference is on fetal cardia for 3 days. And thank you so much for your patient listening.
Thank you so much, Madam, for the lucid and comprehensive talk. If there are any questions from the audience, we can take them.
Thank you for the wonderful presentations regarding the diagnosis and surveillance, all those things. I want to know, ma'am, how frequently we have to do the surveillance for in case of like raised PI or absent or reversed. In what frequency we have to do like?
Shruti.
Raised, that means your umbilical artery resistance is high. There is a forward flow during your diastole. So that falls under stage 1. So whenever you have stage 1 fetus, whether it is early onset or a late onset FGR, all late onset FGR by default falls into the stage 1 category, because there the umbilical artery is always forward flow. Umbilical artery never becomes absent or reversed in a late onset FGR. So in an early onset FGR, when you have a high resistance in umbilical, forward flow in umbilical, it is categorized as stage 1. All stage 1 requires weekly monitoring. When we say weekly monitoring, every week we don't have to measure the biometry to find whether the baby has increased in weight or not. We don't need to measure the Likert to say whether the AFI is coming down or not. What you do weekly monitoring is only monitoring the Dopplers. Because it is the Dopplers that is going to pull them into the second stage. So when you are following the umbilical artery forward flow, and when you see them next week, if you find the flow is still forward, it is going to raise. If you do the graph, the trend in the PI will increase, but it will still be forward. Still it is weekly monitoring. The moment it becomes absent, if the fetus has already crossed 34 to 35 weeks, it is absent, it is time you can steroid and deliver, because it has already gone into the second stage. Second stage delivery is between 32 to 34 weeks. Once it comes to second stage and the baby is still 30 weeks, that means it has not come to that stage of delivery, you can monitor them bi-weekly. In weekly twice you can monitor them, and the moment it reverses or it shows a ductus venosus becoming high resistance, it becomes third stage, in which you need to deliver them by 28 to 30 weeks. So it all depends on the age of the baby, the umbilical MCA, as well as your ductus venosus flow, including your CPR if you are going to do your late onset FGR.
If there is change in the ductus venosus, how long we have, like, is there any time, like for steroids, if it is not given, how long we can wait, or like sudden?
No, ductus venosus, if it changes, it directly pulls the baby to the third stage, which means if the baby has already crossed 28 to 30 weeks, you deliver. Whether you steroid or not steroid is not our concern. If you are going to admit her for observation, you can start giving her 1 dose of steroids, whatever it is. I think obstetricians here can answer how do they manage steroids, because for us you need to deliver. The problem in these babies is they do not come to stage 3 on one day. You had already identified them as a growth restricted baby. You have already identified the trend. They may skip from stage 1 and need not go to stage 2. They can come to stage 3. But at stage 1, you are alerted. So you know that this baby is going on a increasing trend of deterioration. So the steroid, which has an effect of about 1 week, would have been given earlier also. By chance, if you had not given, the patient comes to you for the first visit at that point, it does not matter, because neonatologists have their own way of managing. If you have still not given the steroids, or they admit and give 1 dose steroid.
Thank you, ma'am.
Hi, ma'am. Here. Should we mention stage? Should we mention the stage in late onset growth restriction?
Late onset growth restriction is always stage 1.
Should we mention that stage 1 or we should not mention?
No. You mention if you want to. Does not matter.
Okay.
Because if it is a late onset FGR with a forward flow in umbilical, my monitoring is always weekly. And if it is crossed 37, 38, we deliver. We don't wait till 40 weeks. We don't wait after that. There is no use waiting in a late onset IUGR after diagnosing to pull on after 37, 38 weeks. So whether you put it on paper or not does not matter, as long as you know that you need to call. But the call, when you want to call the patient, has to be in your report. If you want to call her after a week, you have to put it on report. If it is already 37, 38 weeks, you can ask them, delivery can be planned. There is no harm in giving the suggestion that this is a late onset FGR. It has already crossed 37, 38 weeks. You can deliver.
Okay, if it is 34, 35 weeks, we are doing weekly monitoring, then how to decide the delivery? Like before 37, if you want to deliver any emergency like that, how to decide it?
In a late onset FGR, the prognostic marker, that is a marker to deliver, is your CTG, your fetal movements, biophysical movements, especially only the breathing movement, not even your tone and other things. You take into consideration the movement. So every time the fetus comes for your weekly Doppler, they also have to do a weekly NST, and they also have to do a biophysical profile and also ask the mother about the fetal movements.
Thank you.
So that is where they decide, because decision is not taken on your Doppler. You can find your deterioration happening, but you don't decide to deliver. But the obstetrician decides to deliver based on their NST. So suppose if you say today it is 34 weeks and the late onset FGR, if the NST is good, we will prolong. Next visit, like that. And everything is weekly.
Thank you, ma'am.
In multiple pregnancy, it depends on whether it is a dichorionic or a monochorionic pregnancies, because we have an interesting case coming in the panel on twins with growth restriction. I think the entire thing will be elaborated there, but it depends on the chorionicity as well, and also on the fact that that can be a selective IUGR. In a fetus, in a monochorionic fetus, one can be growing normally, one can have a selective FGR. So there the protocol becomes different. So that will be told to you in the panel.
Good morning. I
Yes,
have a question. Sorry, I missed your talk. But my understanding is that the CPR ratio should always be more than 1. Of late, I've been seeing a few reports where they give a percentile. So is there any new guideline for that?
No. CPR ratio more than 1 never holds now. We always need to show the trend in CPR, because that is what you are monitoring during your late onset FGR. You are not monitoring your umbilical artery because you know it is forward. You are not monitoring your MCA because it still is not redistributed. So they both may look normal as far as percentile is concerned. Whereas when it comes to CPR, today the CPR was 1.3. I do it after a week and I find it as 1.1. If you take only more than 1 is normal, that is also normal. But then the trend is coming down. The downward trend in CPR shows that there is a deterioration in this fetus. So your monitoring with respect to NST, fetal movements and other biophysical profile should be there much more cautious when you see a downward trend in CPR.
Sure, that's okay. But our decision to deliver will be based on a CPR which is falling less than 1. Till 1, we are still okay.
No. CPR is not a marker for delivery at all.
One of the markers. I'm not saying the only marker, but as long as the CPR is more than 1, we are still
deliver
okay.
based on CPR. If the baby has not reached 37 weeks, CPR is showing a downward trend. Forward flow in umbilical is there. Your NST is good. Your biophysical is good. You don't deliver even if your CPR is 0.9.
Right.
You don't use CPR to deliver the baby. You only use the CPR to understand the severity, But once it reaches 37 weeks, everything else is fine. Your CPR is 0.9. You can ask them to deliver because you don't want deterioration, because deterioration in a late onset FGR is abrupt. You land in IUD one day, that's it. You land in problems in neonatally, postnatally, immediate postnatal. So we don't want that. So that is why. So you don't use CPR to deliver, but you understand the disease better by looking at the CPR. But if your NST is good, you still prolong.
My question was about the
Yeah, tell me.
My question was also about the percentiles. We are seeing a lot of reports where they are reporting the percentile. CPR is at the 2nd percentile, 5th percentile. So is there a cutoff that is, something that we should be aware of?
Percentile is just for us, just like any other graph, no? For us to understand. From the 5th percentile, it has come down to 2nd percentile. That means there is a downward trend. That is all it shows.
That's all.
That's all it shows. Whether you show the graph, whether you put it as words in as percentile does not matter.
Yeah, CPR is to evaluate the progression of the disease, not for intervention. Now, Chitra, my question is, in a low-risk pregnancy, in a normal pregnancy, we do the dating scan, we do the scan at first trimester, we do the anomaly scan. Now, the next scan should be scheduled at 32 or 36.
That again is depends, because if you are having a normal anomaly scan at 22 weeks, the thing whether you want to do a growth scan either at 34, 36 is only with having late onset in your IUGR or whatever it is in your mind. It is not about the late onset evolving anomalies. There are anomalies which can evolve at 28 weeks, 30 weeks. So if you want to, your mid-trimester scan is not ruling out all the late onset anomalies. So you do not wait till 36 to do an interval growth scan, because if you pick up an dilated bowels for that matter, or an anomaly which is a late onset, then difficult in counseling the patient. So we always do one scan at around 28, 30 or 32 weeks to rule out that, also identify whether the growth is normal, and then 36 weeks is the ideal time. 36 weeks scan should be definitely done, because many late onset FGR sometimes present at 36 weeks. Though we say from 32 week onwards you can identify them. Anything which is above 32 weeks is late onset, but majority of them can present at 36. So it is important that when you are asking for a late, that is end-term scan or whatever it is before your delivery, ask it at around 36. So you still do your interval growth scan at 32. That is for other purposes along with your late onset plus your 36 week scan.
Good morning, ma'am. Ma'am, I have a question. Suppose we see a patient for the first time, Dopplers are abnormal, say ductus venosus, everything is abnormal, they've not been steroided. We put them on continuous monitoring, and can we still steroid them by some time with continuous monitoring with CTG?
Gestational age?
I mean, ductus venosus is abnormal irrespective of the gestation.
You're talking about early onset FGR.
Whatever it is, maybe say more
late
than 20.
Onset FGR will never show ductus venosus problem. So late onset FGR, there is no problem apart from only the CPR doing changes. So if you talk about ductus venosus,
if it's more than 34 weeks, anyways we will take up. Say it's between 28 to 34. We have not steroided. There are severe Doppler changes like ductus venosus changes and all. We want to buy some time to give the steroids. Can we put them on continuous monitoring?
No. If ductus venosus is already showing changes, that means the baby is already third stage, which means you have to deliver them at 28, 30. If you have already crossed and have come to 32 weeks, it is better to deliver rather than make the baby
between
much more
28 to 30 weeks, you say that gestation.
28 to 30 weeks you have to deliver, that's it. Whether you give steroid or whether you want to wait is, it's
no ma'am, with continuous monitoring, we will be monitoring with continuous CTG.
No, it's not about, see this early onset IUGR will not die abruptly. It is a problem which comes in the neonatal period. You will be putting a fetus which is much more stressed out rather than one which is lesser if you deliver it at that time of...
So whether we steroided or not, irrespective of that, if those changes are there, we deliver.
We deliver. But generally steroids are nowadays used more rather than underused. No? In fact, people start giving steroid. The moment FGR is identified, they give a steroid. So, okay, I think we have enough discussion. This is only the first talk. So we'll move on to the second.
You can always have a lot of questions to Dr. Chitra Ganesh in the lunch time. Okay?
Thank you.
Thank you,
so much, madam. A lot of learning and very engaging discussion. So moving on, I now invite Dr. Soumya to talk about postnatal recognition of FGR. Welcome, Dr. Soumya.
ಇಟ್ಕೊಳ್ಳಿ ಕ್ವಶನ್ ಕೇಳಿದ್ರೆ ಆಮೇಲೆ ಹಿಂದೆ ಒಂದು ಇಟ್ಕೊಂಡೆ.
Okay. A very good morning to everyone. I would like to introduce you to the postnatal recognition of IUGR. So coming to the definition of IUGR or fetal growth restriction, it is defined that when the rate of growth of a fetus is less than normal for its expected growth potential for the gestational age. So it's a clinical definition. It includes neonates with evidence of malnutrition at birth. There are IUGR babies are associated with significant perinatal morbidity and mortality, and IUGR can affect preterm, term, and post-term neonates. So it's 24% incidence is 24% worldwide. Most of the burden is seen in Asia, where the incidence is 75%, and in India, is according to recent data, the incidence is 26 to 28%. So we often use the terms SGA and IUGR synonymously, but there is a slight difference between the two. So SGA is small for gestational age when the weight of the baby is less than 10 centile in growth charts for that particular gestational age. It does not take into account the clinical features or the in vitro growth retardation into account. Whereas IUGR is when the weight is less than 10 centile with clinical evidence of malnutrition. The term LBW is a separate entity which includes newborns born with a birth weight of less than 2.5 kg irrespective of the gestational age. So as we all know, there are 3 stages of fetal growth. First stage is the stage of cellular hyperplasia, which lasts till 20 weeks, where there is increase in the number of cells and lot of mitosis which happens. And the second stage between 20 to 28 weeks is the stage of hyperplasia and hypertrophy, where along with the cells getting divided, there is increase in the size of the cells. And the third stage is the stage of cellular hypertrophy, which is beyond 28 weeks, where there is decline in the cell division, but the cell size grows on increasing. The point to note here is that brain growth usually occurs during the early stage of fetal development, whereas adipose tissue and skeletal muscle growth occurs in the later stages. So based on the stage of insult, there are 2 major types of IUGR seen. Postnatally, symmetrical IUGR, who are also called as hypoplastic small for dead babies, where the insult occurs early in the gestation, and asymmetrical IUGR, who are malnourished babies at birth, where the insult occurs in the late gestation, usually due to uteroplacental insufficiency. And a separate entity called mixed IUGR is seen in developing countries, where a symmetrical IUGR, when later gets affected by uteroplacental insufficiency, can present some of the features of both types of IUGR. So these are the major differences between symmetrical and asymmetrical IUGR. Fortunately for us, asymmetrical IUGR is the most common type, where the incidence is 70 to 80%, where the insult occurs in the late gestation. The etiology of symmetrical IUGR is usually genetic factors or intrauterine infections like torch infections, whereas uteroplacental insufficiency is the major cause of asymmetrical IUGR. Ponderal index, which is the weight by, which is the ratio of weight by length cube, is more than 2 in symmetrical IUGR, as all the parameters are proportionally reduced, whereas in asymmetrical IUGR, the PI is usually less than 2. In antenatal scans, as madam already said, all the parameters are proportionally reduced, like head circumference, abdominal circumference, femoral length, and biparietal diameter are proportionally reduced in symmetrical, whereas in asymmetrical, only abdominal circumference is reduced. So cell size is reduced in asymmetrical IUGR, and cell number is reduced in, this is only for theoretical purposes. And anthropometry, postnatal anthropometry wise, weight, length, head circumference is all reduced less than 10 centile in growth charts in a symmetrical IUGR, whereas weight is less than 10 centile, but head circumference length is usually normal in asymmetrical due to brain sparing effect. So features of malnutrition are more pronounced in a asymmetrical IUGR, and prognosis is better in a asymmetrical IUGR, again due to brain sparing effect. So this I'll not go into detail, genetic, maternal and fetal and placental causes, as we all know. So coming to the topic per se, which is postnatal diagnosis. So the major modality of diagnosis is by clinical examination and anthropometry. There are other supportive indices, which is ponderal index, which has already been discussed, and clinical assessment of nutrition score. Cephalization index, which is a ratio of head circumference by body weight, and mid-arm by head circumference ratio less than 0.27. This is only for term IUGRs. So coming to the clinical examination. So this is a 36-week, 1.6 kg IUGR born to a mother with severe preeclampsia. As we can see, there is a large head compared to the rest of the body and loss of buccal pad of fat. There is poorly developed breast bud formation. The rib cages are visible. There is scaphoid abdomen, and loose folds of skin are seen in the nape of the neck, the axilla, groin, and buttocks. So this is just a schematic representation to show all the clinical features that are evident at birth. The baby has a large head compared to, this is mostly in asymmetrical IUGR. The baby has a large head compared to the rest of the body due to brain sparing effect. The AF is wide due to defective membranous bone formation. The baby is usually hyper alert, and there is loss of buccal pad of fat giving rise to the old man appearance. The arms and legs are comparatively long compared to the rest of the body. The skin is dry and peeling. There is scaphoid abdomen, poor breast bud formation. The umbilical cord is usually thin, and there is loose folds of skin which are seen in the nape of the neck, in the interscapular area, in the buttocks, and in the inguinal area. So another thing to keep in mind is the Ballard score, which we usually use for assessment of gestational age, is inaccurate in these babies, as a Ballard score is physical as well as neurological component. The physical components in these babies are usually underscored or overscored. This is because due to diminished blood supply to the skin, there is reduced vernix formation. So because of that, the skin is continuously exposed to the amniotic fluid, and this leads to continuous desquamation, and hence the palmar and plantar creases appear mature even in preterm IUGR babies. There is also less well-formed ear cartilage. Due to reduced blood supply, reduced adipose tissue formation, and low estradiol levels, the breast bud is small. And due to reduced adipose tissue deposition in the labia majora, the female genitalia usually appears less mature, whereas the neurological components can be scored adequately. Coming to the symmetrical IUGR, as we know, the causes of symmetrical IUGR are usually genetic chromosomal anomalies or Torch infections. We will be looking at the same features. There will be dysmorphism, congenital anomalies seen, or features suggestive of Torch infection, like there could be microcephaly or macrocephaly, there could be chorioretinitis, conjunctivitis, or cataract. There could be hepatosplenomegaly, skin petechiae, or blueberry muffin rashes that can be seen. This all suggests that we need to screen for Torch infection. So coming to the anthropometry, the postnatal growth charts, what we use are Fenton growth charts. They are separate for male and female babies. So in asymmetrical IUGR, we can see that the weight is less than 10 centile, but the head circumference and length is usually maintained. Whereas in symmetrical IUGR, all weight, head circumference and length are all less than 10 centile. Coming to the clinical assessment of nutrition score. So there are 9 components, including hair, cheeks, neck and chin, arms, legs, back, buttocks, chest, and abdomen. So each component is scored with a minimum score of 1, which says there is some malnutrition, and maximum score of 5, which indicates normal nutrition. The total score is 36, and a score less than 25 suggests IUGR. So this is a picture to differentiate between, to compare an average size baby at term with the baby with IUGR. We can see that there is a large head and rest of the clinical features as discussed previously. This is another picture showing a preterm IUGR at 34 weeks at the left, and a comparison between a term IUGR versus AGA baby at 39 weeks. Again, the baby has the old man loss of buccal pad of fat and scaphoid abdomen, long arms and legs compared to the rest of the body, large head, all the typical clinical features. So just brushing upon the common problems faced in the immediate and the late, immediate newborn period and later in life. So these SJ babies we have to recognize and treat. For these complications are expected: perinatal depression, hypothermia, hypoglycemia or hyperglycemia, hypocalcemia, polycythemia. There can be persistent pulmonary hypertension, pulmonary hemorrhage, meconium aspiration, feed intolerance due to NAC, and retinopathy of prematurity. There are also neurodevelopment and cognitive complications which can present later on in life, which are most commonly seen in symmetrical IUGR babies, but also in asymmetrical IUGR if there has been an perinatal insult like perinatal asphyxia or hypoglycemia or an NAC complicating the immediate newborn period. So these are all the neurodevelopmental complications which are seen. Also, a topic of interest is the development origin of health and disease, which is the thrifty phenotype or Barker's hypothesis, which says that due to adverse events occurring intrauterine, the fetus adapts itself to survive in that adverse environment by making certain changes like brain sparing in expense of other organ systems, and reduced secretion and sensitivity to insulin and insulin-like growth factor, and upgradation of the HPA axis. So these changes, when they occur during a critical period in the fetal growth and development, these get programmed into the fetal genes. And when later on in life, when they grow, when they are exposed to adverse environmental factors like overnutrition or sedentary lifestyle or reduced physical activity, they are more prone to develop many of the metabolic diseases like type 2 diabetes or hypertension or syndrome X. So this is just to brush up on that. So this concludes my short talk on postnatal recognition of IUGR. Thank you for your time.
Thank you so much, Soumya, for the crisp and clear talk. I now request Dr. Bhaskar to please come and talk to us about our experience with FGR babies over the past 1 year.
Hi, good morning everyone, and thanks for coming. So, in the past 1 year, we have seen almost around 7 to 8 cases of IUGR babies in our NSU. I'm going to discuss about one case which we had little difficulty for us and also for the parents, and other things I will briefly brush up. And other 2 cases will be discussed in the panel discussion. Yeah. This is baby born to G4 P3A1 mother, breech vaginal delivery, breech presentation, 30 weeks, birth weight was 1 kg. It was delivered in Kaveri hospital also. So mother had a history of PIH, absent acid flow in umbilical artery and Dopplers. After 2 hours from we took the child to our NSU. Child was started on CPAP, TPM and antibiotics as usual. Day 2 we started feeds. So we have a routine of putting colostrum painting on the oral mouth painting. Initially, when we started our NSU, used to happen after a day and so. But now after training our labor ward sisters, even our NSU sisters, we do within 4 hours now. So on day 2 child, we started feeds. Day 3 child developed abdomen distinction. So followed by bilious aspirates with a suspected sepsis. We kept NPO because child was transferred from the other hospital and also the transport was involved. So then after antibiotic, day 9 again we started topic feeds. So we give express breast milk or donor's breast milk because we have Dr. Srinath here. So he's always insisting on donor's breast milk. And we start gradually increase the feeds. Again after 4 days, child developed abdominal distinction with bilious aspirates. This time we had abdominal wall edema also. We took an ultrasound, ultrasound suggestive nothing except that bowel loops, and the X-ray also showed distended bowel loops and abdominal wall edema. Blood report showed hyponatremia, platelets were low, thrombocytopenia was there. CRP is 5, which is high, our values are 0.5 is the normal, less than 0.5 is our normal. So again, and child was kept on NPO, we antibiotic, we stepped up, we took a pediatric surgeon, we want him to keep in loop if at all next anything should be done. So we also suggested continue with the medical line of management. Over the days, the platelets went down into 20,000 and we had a bloody aspirates from the NG. So we need to transfuse the child on with platelets, antifungal was added. By then we got a culture report suggestive of Klebsiella. Already child was on antibiotic, but luckily it was the same sensitive pattern. The antibiotic what we were given was sensitive to Klebsiella. Then day 18, after 4 days, again we restarted feeds. This time even we were also felt bad and parents were also a little anxious because third time again child had bilious aspirates along with abdominal distinction. Again we need to step up antibiotic. though we were giving an IRA antibiotic at that point of time. So then after 4 days, again we thought this time at least it's worked out. Luckily, then we were able to eat full feeds by day 34 of life. Baby got discharged by day 43 with weight of 1.42. Now presently child is, this is child. Okay, presently child is 9 months old, 6 kg, nothing. You can see the naughtiness in the child face. Yeah. So other cases, I'll just brief out. It's in case 1, we had an 31 plus 1 weeker 700 grams. Doppler sporoma reversal flow was there in umbilical artery. Mode LSS delivery was done. So there was no, except CPAP, there was no ventilation, there was no sepsis, anesthesia or anything in this child. Time of reach of full feeds was day 9 in this child, and regain of birth weight was day 11. Case 2, 33 weeker, 1.2 kg, same. These were abnormal Doppler. This also child reached full feeds by day 8, and time of regain of birth weight was day 12. This is 28 plus 2 weeker, 650 grams. Child had leaky PV with oligodromias, LSES were done. So this child had ventilation on NIV for almost 20 days. So we discussed probably in the panel discussion. And time to reach feeds in this child was 47, and time to regain birth weight was day 40. Case 4, 35 weeker, 1.55 kg. Was preeclampsia indication, LSES was done. So we all NSU was stay was uneventful. Day 11 we reached the full feeds. Time of regain birth weight was day 9. And 36 weeker, 1.46 kg. This child on day 4 had feed intolerance in terms of abdominal distension, vomit, not a bilious vomiting. We kept NPO for 2 days, and luckily everything settled. CBCs, everything were normal on that child. But day 12 we reached the full feeds, and time to regain birth weight was day 10. And the last case, that is 31 weeker, 1 kg. It's a normal delivery. So now we have improved. Now day 8 only we reached full feeds, and time of regain birth weight was day 11. Yeah. Thank you. This is our short experience with IUGR babies.
Thank you, Dr. Bhaskar. Moving to the next talk, I would invite Dr. Deepthi Raghuram, our dynamic fetal medicine consultant, and she will be speaking on antenatal findings in FGR.
Thank you, sir. So good morning, everyone. So this talk for the next 20 minutes is going to be findings in an ultrasound that we look out in a case of an IUGR. And Dr. Chitra madam has made the job really easy for me. So it's going to be based on antenatal literature and how it helps us to interpret these findings to make the decision on when to deliver. So the talk is mainly based on the Gratakos landmark paper that came out in 2014 for the stage-based management in fetal growth restriction, and the most recently published guidelines by the International Society for Ultrasound in Obstetrics and Gynecology on fetal growth restriction. So there is, without Doppler, there is no IUGR. So it is the Doppler that is the mainstay of the talk, and I'll also be discussing about the other things that we would look out in an ultrasound. So in the Dopplers, we see the maternal uterine arteries and the fetal Dopplers, which is basically the umbilical artery, middle cerebral, and the ductus venosus. Let's go into in-depth about each Dopplers. Before that, basics of placenta, it is a two-compartment organ. So there is a maternal compartment, which is basically the uterine artery, and the fetal compartment, which is basically the umbilical artery. So in uterine artery, we see the maternal supply, and the umbilical artery, we see how much the fetus is able to extract from the placenta. In other words, it's the placental resistance that we look at when we interrogate the umbilical artery. So uterine artery, as we said, it's maternal supply. Normally, there is a low resistance flow, and this is how a normal uterine artery looks. So we have a systolic wave. right up there, and the diastolic wave, and we see a forward flow throughout the cardiac cycle, and the resistance is quite low. This is how an abnormal uterine artery looks, wherein we see a diastolic flow which is considerably lesser than the systolic wave, and the pulsatility index in these cases is much high. So when we have a high resistance flow in uterine artery, 1, it is a predictor for maternal preeclampsia. 2, it helps to diagnose IUGR, but it does not have a prognostic value. Okay, so moving on to the fetal Doppler. Before that, let's just go into the concept of early and late onset IUGR. And based on this conceptual difference, there is a difference in our monitoring and the decision to deliver. In early onset IUGR, to start with, the fact that it presents early on represents that the placental disease is more than 30%. So a disease of more than 30% is required for the umbilical artery to show a change. So when we have a placental disease to start with, there is a change in the umbilical artery, which is representing the placental resistance. And when the placental resistance increases, the heart has to pump more and the heart cries. When the heart cries, that is reflected in the ductus venosus. So it is basically the umbilical artery and the ductus venosus that we look at in early onset IUGR cases. And what happens to the middle cerebral artery in these cases? There is a resistant circulation, there is chronic hypoxia, and there is hypoxia in the brain, which is represented as the cerebral redistribution in all cases of early onset IUGR. But fortunately, at this point, the early brain is not very sensitive to hypoxia. Hence, we do not base our decision on delivery, or we do not take into account the MCA or CPR in an early onset IUGR. So it is the heart that works the most in early onset cases. In late onset IUGR, the fact that it presents late implies that the placental disease to start with is very, very, very less. So there is a placental disease of less than 30%. So umbilical artery, it is not sufficient enough to cause a change in umbilical artery. Umbilical artery would be normal. The heart is happy. There is no change in ductus venosus. But at this point in the late onset case, the brain is highly sensitive to hypoxia. So even at that amount of resistant circulation and the hypoxia, the brain is calling for help. And there will be cerebral redistribution in the MCA. And that is the reason why we look at the MCA and CPR in late onset IUGR, and it is the brain that is flattened out in late onset IUGR cases. Moving on to the individual Dopplers. So this is the umbilical artery, which represents the fetal extraction or the placental resistance. Normally there is a low resistance flow as seen in the picture above. And whenever there is a placental disease of minimum 30%, the umbilical artery shows us a change. And the pattern, as Madam had already mentioned, it depends on how much the placental disease is. So there is an absence of end diastolic flow when the pattern is around 60% affected, and reversal when there is 70% affection. So does this have a clinical significance? Yes, because studies have said that whenever there is an absent end diastolic flow or a reversal of end diastolic flow, it would mean that acute deterioration is going to happen in the next 1 week. So when we have an absent end diastolic flow, it would suggest that the fetus is already hypoxic. And in such cases, deliver by 34 weeks. And if we do not reach 34 weeks by then, when the baby is already showing absent, follow these fetuses quite frequently, and the recommended interval is bi-weekly. If there is a reversal of end diastolic flow, it would mean that the baby is already acidotic. In such cases, deliver by 30 to 32 weeks at the max. And if we have not reached that stage, monitor these fetuses every 1 to 2 days. So insunating the umbilical artery itself in high-risk pregnancies reduces the perinatal death by 30%. And umbilical artery is the only artery which has got a diagnostic role, one to identify IUGR, and a prognostic role to determine the time of delivery. So what is ductus venosus? Yes, it represents cardiac function. So it is basically the shunt. It is the shunt that connects the umbilical vein to the heart, so that the oxygenated blood from the umbilical vein reaches the left heart and the brain. So that is the idea of ductus venosus. normally there is a low resistance flow and it has got a typical triphasic flow. So that has got 3 waves. It has got an S wave, D wave and an A wave. Out of this, the A wave is the one that is of most importance to us. A wave represents the atrial contraction phase of the ventricular diastole. So when there is a pressure overload in the heart, during the atrial contraction, there is an increase in pressure on the heart, and that is reflected backward in the ductus venosus as either reduced A wave or a reversal of A wave. The reduced A wave, we call it as a high resistance flow in ductus, and a reversal of A wave is what we call it as the reversal of the ductus venosus flow. Let's go into depth. So when there is an abnormal in ductus venosus, it's the strongest predictor for short-term risk of fetal death in early onset IUGR as it correlates with fetal acidosis. Okay, so next question that Dr. Gayatri had asked, whether we should deliver whenever we have a ductus venosus abnormality? Yes, of course. But the advantage of ductus venosus is it precedes changes in biophysical profile and precedes changes in the short-term variability in a computerized CTG. So we have enough time to prepare the patient, to prepare the attender, to prepare the OT, because whenever we see a change in ductus venosus, we have to deliver. So we have a ductus venosus showing a high resistance flow, then there is a low suspicion of fetal acidosis, deliver by 30. If not, if you have not reached 30, monitor every 1 to 2 days. If we have a reversal of flow in ductus venosus, there is a very high suspicion of fetal acidosis, deliver by 26 weeks after a course of steroids, and that is what the studies have said. That said, when we have a ductus venosus abnormality, we have an early onset IUGR which we are monitoring. Do we wait for the ductus venosus to show change, or do we have a combination with which we assess? So the truffle study says, when there is a Doppler abnormality in ductus venosus, always use it in conjunction with a CTG and base your decision. So always it's a combination of the history, maternal blood pressure, maternal perception of movements, the Doppler indices and CTG, which would help us in making a decision to deliver, and not just one single abnormality in the Doppler. So ductus venosus has this pure prognostic role. Moving on to the middle cerebral artery, it represents the fetal oxygenation and normally is a high resistance flow in the middle cerebral artery because the brain is well protected. But in late onset IUGR, whenever there is a mild placental disease and the mature brain is highly sensitive to hypoxia, there is cerebral vasodilatation and redistribution in the MCA. And this is of importance to diagnose late onset IUGR, and as they have already mentioned, it is not to time the delivery. And that is what ISWOG has told us. Though the cerebral redistribution is associated with adverse short and long-term outcome, there is currently no evidence as to how cerebral Doppler should be utilized in the delivery timing of FGR. Moving on to the cerebroplacental ratio. Yes, it's a combination of MCA and UI. Because it's a combination, the sensitivity that it provides is much, much more than MCA alone. Even when the individual components are within the normal range, the CPR can show a change. But it is not specific, it does not correlate with acidosis or hypoxia, and you cannot time the delivery based on this. And CPR as well, when it is less than the 5th centile, you increase the surveillance, and it is a diagnostic marker for late onset IUGR. Okay, so in late onset IUGR, which is better, whether we should use MCA or CPR? So here we have an answer way back in 2011 by the same Gratikos group, and they said in the graph that the CPR shows a drastic change over a period from 30 to 40 weeks. But MCA shows a stable course. So it remains more or less stable over the course of 30 to 36 weeks, while CPR shows a drastic change, because of which it is more a sensitive parameter to use for monitoring in late onset cases. And ISWOG also says, if you have cerebral redistribution showing a Doppler downward trend in CPR, do not go beyond 38 weeks and 6 days. A word about aortic isthmus Doppler. It's a very technically challenging Doppler to perform, and that is the reason it is not commonly reported in most of our ultrasound reports. Other than that, there's one more reason to it. So let me just go into the anatomy of the aortic isthmus. So this is where the aortic isthmus is. It is at the junction of the transverse arch, the ductal arch. So the flow at the aortic isthmus is influenced by the flow from the left ventricle into the aortic arch, flow from the right ventricle into the ductal arch, the cerebral circulation and the cerebral resistance, and the placental resistance. So if we have a reversal of flow at the aortic isthmus, it is an interplay of all these four, and we really do not know which one is at fault. So this is one of the reasons why aortic isthmus Doppler has not gained importance. And there is another reason that this change in the aortic isthmus Doppler precedes ductus venosus abnormality by 1 week. And hence, it cannot be used as a short-term predictor of fetal demise, and hence it has not become really popular. But the studies have said, even when the ductus venosus is normal, if the aortic isthmus is showing a reversal, there is a very strong association with neurological morbidity. But as such, we would need more robust data before we act on this finding, and it is still in a research setting. So aortic isthmus has got a pure prognostic role. So among the Doppler indices, there is pulsatility index, resistance index, and SD ratio. And the ISWAG tells us that it is the pulsatility index which is we commonly use. Why does it say so? As we can see here, pulsatility index takes into account the average flow across the cardiac cycle. And it is said that the pulsatility index shows a linear relationship with the vascular resistance instead of the others. So hence, PI is the most commonly used index as far as antenatal Dopplers are concerned. As Madam was mentioning, early onset IUGR, because it presents early, there is enough time for the individual Dopplers to make a change in its course. So it always follows a cascade of events. So there is a predictable event that happens. So initially there is chronic phase wherein we have a Newton artery showing high resistance, umbilical artery showing high resistance. MCA as usual will have a low resistance flow in the initial phase, and in the later acute phase we have changes in the umbilical artery developing absent or reversal, and the ductus venosus showing the changes, and finally the CTG. So it is a cascade of events in early onset IUGR, and I would like you to look at this. This acute changes that happens in early onset IUGR happens for the next 7 to 10 days, and that gives us enough time to act on it. That said, the actual duration of each phase, how long the umbilical artery is going to show a high resistance flow, when it is going to become absent, that cannot be predicted, and that basically depends on the severity of the underlying disease. And also, most importantly, when we have a coexistent preeclampsia, we really cannot predict how it is going to go. It can distort the natural history, and any acute deterioration can happen anytime. But what happens in late onset IUGR? There is not enough time. That itself presents late, and the umbilical artery and ductus venosus is not going to show any change. There is going to be a change mostly in the MCA, and herein we can see that the acute deterioration happens in hours. And that is the reason why we are very much worried, because sudden IUD can happen any time in late onset IUGR. Though the placental disease as such is very less in late onset IUGR, we are very much worried. One, it is getting missed because the umbilical artery is normal. Two, acute deterioration can happen any time, so which will require us to monitor these fetuses quite frequently. So what is the management in late onset IUGR? Whenever there is a CPR of less than 5th centile, increase the surveillance. Monitor these fetuses bi-weekly. That's what the studies have said, and ISWAG approves. When we have a more than 34-week fetus and the CPR is falling MCH less than 5th centile, monitor these fetuses bi-weekly along with weekly CTG. So only the CTG will predict response of the brainstem to hypoxia, and we do not have a good Doppler tool to predict acidosis in late onset IUGR. So always listen to the mother, and when we have a 37-week mother who's saying probably a reduced fetal movements, not just go with Dopplers, always listen to the mother, and it would be better to deliver such pregnancies rather than continuing when we are already reached 37 weeks. So we are done with Dopplers. Moving on to the growth velocity. So in the growth velocity, I would like you to look into this graph of an abdomen circumference, wherein we see that there is a fall of the abdomen circumference from around 80th centile to 5th centile. So there is a drop of more than 50 centiles. This loss of 2 quartile is itself a contributory marker for late onset IUGR. So it is not just the growth on that particular day, rather than the interval that is of most importance. Other than the growth interval, we also plot the individual artery PI. So herein we see an umbilical artery which is within the normal limits. It's between the 5th and the 95th centile. And we have a middle cerebral artery that is also within the normal limits. But if you see the trend, we see that the umbilical artery is increasing and the middle cerebral artery is decreasing, but it is still within the normal limits. And when we follow up the CPR, we see that there is a sharp fall into the 5th centile. So it is the Doppler trend that is of most importance, and not just the absolute values in that particular visit. Moving on to the role of biophysical profile. So biophysical profile is a combination of ultrasound and the NST, the fetal heart reactivity. On ultrasound, we look at the fetal breathing, fetal tone, gross body movements like a volume, and the NST is the fetal heart reactivity. Yes, what does it represent? It basically tells us how the brainstem responds to hypoxia. So they say there are breathing centers and the fetal heart reactivity centers in the brainstem which would get affected if there is a hypoxia, and that change will be able to identify by a biophysical profile. But unfortunately, meta-analysis have said in high-risk pregnancies, this actually causes a high false positive rate, and it is not of highly significant benefit. And the reason that they quote is, though fetal breathing and fetal heart reactivity will be affected in late onset IUGR cases, this happens just shortly before stillbirth. And hence, it cannot be useful in determining the monitoring intervals. So when we have a Doppler expertise or a computerized CTG, if it's available, then the use of BPP as such is still a question. If we do not have, yes, biophysical profile, it's of use. What is the role of amniotic fluid index to end with? And this is beautifully depicted by this graph. In a case of an IUGR with oligohydramnios, over a course of 8 weeks, the amniotic fluid index remains stable. So it neither predicts hypoxia nor acidosis. And hence, monitoring in a case of IUGR with AFI has got no role. So the take-home points that I would like to mention are: in early onset IUGR, it is the heart that's broken. Look at the umbilical artery and ductus venosus and base your decisions on that. In late onset IUGR, it is the heart, it's the brain that gets flattened out. So look at the MCA and CPR. Look at the Doppler trend and growth interval rather than absolute values. Management is always a combination of history, maternal blood pressure, perception of movements, Doppler indices, and CTG. There is a limited role for biophysical profile, and there's no role for AFI. Thank you so much for patient listening instead of this baby which is highly yawning. Thank you.
Thank you very much, Dr. Deepthi, for such a wonderful talk. We have time only for 1 or 2 quick questions, if you have. If you can raise your hands, any of you have a question? Okay, we'll move on. We can actually ask the questions during the lunchtime. So we have learned about Doppler changes in FGR and how it translates to neonatal outcomes. I invite my dear friend and colleague, Dr. Tejal, Senior Consultant Neonatology, to talk about what are the implications in neonates. Thank you.
So good afternoon. Good afternoon. Good afternoon, everyone. So we've had so many We've had so many wonderful talks from this morning, talking all about antenatal surveillance and the scope of antenatal Doppler. So we wanted to look at this antenatal surveillance from a neonatologist perspective, and in the matter of next 15 minutes, I hope to tease apart what it means for us. What, when the obstetrician tells us that this baby has abnormal antenatal Dopplers, does it mean anything for us? And what are the special perspectives that we should keep in mind? So the entire premise or the entire central construct of antenatal surveillance is based on, umbilical artery Dopplers or the CPR or the MCA Dopplers, as my esteemed colleagues have been talking about. So just to quickly look at this Cochrane database review, which included 18 studies that had about 10,000 women. And Doppler, they concluded that the use of Doppler ultrasound, which is, they are talking about umbilical artery Doppler ultrasound here, in high-risk pregnancy was associated with a significant reduction in perinatal mortality. What they did not find was a difference in the stillbirth rate, and they also said that where Doppler ultrasound was used, there were fewer cesarean sections, fewer inductions of labor. There was, however, no difference in the operative vaginal births or Apgars of less than 7 at 5 minutes. They did not talk about neonatal morbidity and neonatal mortality because the data was very heterogeneous. So we have been talking about early Doppler changes and late Doppler changes, and how the worsening of the fetal Dopplers probably signals, hypoxemia transitioning into hypoxia, and thereafter acidemia, all our entire goal being to prevent all these adverse outcomes for the fetus. So by logic, one can probably draw a conclusion that worsening fetal status probably translates into worsening newborn status. So our aim is to try and tease out this data and see if abnormal antenatal Dopplers by themselves add on additional morbidity for the newborn over and above the fact that prematurity and IUGR themselves create a lot of morbidity for the newborn. So we know there are 3 pieces to this puzzle. One is that the antenatal Doppler monitoring is being done with a goal of reducing fetal morbidity and mortality. The second piece is that growth restriction by itself is an independent predictor of morbidity. The third piece that we are trying to answer is do abnormal Dopplers signal worse outcomes? So let's first look at short-term outcomes. In this study, they looked at the perinatal outcomes of growth-restricted fetuses with abnormal umbilical artery Dopplers compared to growth-restricted fetuses with normal umbilical artery Doppler. So 170 pregnant women with growth-restricted fetuses were included in this study. 133 of them had normal umbilical artery Dopplers, 37 abnormal. About 70% of abnormal umbilical artery Doppler patients gave birth by cesarean section, so more of operative births. And most of these cesarean sections happened for reversed or absent end diastolic flow velocity. So when we look at the immediate outcomes, it is very obvious. When you look at the low 5-minute Apgar score, or the need for resuscitation, the need for NICU admission, RDS, neonatal sepsis, hyperbilirubinemia, and early neonatal death were all significantly more in the abnormal umbilical artery group. What we, however, also need to look at is that the gestational age of babies born with abnormal umbilical artery Dopplers was also significantly less. So we had more of preterm babies in the abnormal umbilical artery group. So that is a significant confounder to our results that we saw in the slide preceding. Another study, which is a retrospective study, they looked at about 70 women to evaluate differences in prognosis of fetuses with umbilical artery AEDF, that is absent, or reversed end diastolic flow. And they compared it with babies who had only fetal centralization. So now my colleagues have already talked about what is fetal centralization. Basically increased umbilical artery PIs and dropping of cerebral redistribution, MCA PIs decreasing. So here we can see that the NICU admission rates were significantly high for absent end diastolic babies who had absent end diastolic flow and those with reversed end diastolic flow. The babies with reversal had significantly higher need for NICU admissions. The neonatal mortality also was significantly high, and the perinatal mortality was higher when both these groups were combined and compared with babies who had only fetal centralization. So the conclusions here are that low gestational age, birth weight, NICU admission, use of mechanical ventilation were all higher in the AED and REDF group. Again, the same parameter comes in here, is that, and this is a very nice graphic representation. When you look at the white graphs here are the fetal centralization, the AED is the black, and the reversed end diastolic flow are the gray columns. You see that all these outcomes are significantly more in the reversed and absent end diastolic flow groups when compared to babies who had only fetal centralization. However, when they compared for gestation, the only parameter that remained significant was perinatal mortality. So we are again looking at prematurity and low birth weight as a significant confounder to these results. Another study, this is a study from Thrissur, where they looked at outcomes of babies born to mothers with umbilical artery Dopplers. 200 women were inducted into this study, and the forward end diastolic flow group, there were 167. When I say forward, they had reduced diastolic flow, but not absent or reversed. So in the forward end diastolic flow group, there were 167 women. In the AREDF, you can see that there are 34. Once again, you can see that the stillbirth and the neonatal death rates are significantly higher in the AREDF group. But also, just go forward here. So when you look at all the other immediate neonatal outcomes, they are also significantly higher in the AREDF group. Once again, prematurity is a confounding factor. Babies in the AREDF group did arrive early. Was that the only factor that caused increased outcomes, increased immediate neonatal morbidity? Remains to be seen. So a brief bit about ductus venosus Doppler. It has been talked about. So DVPI of more than pulsatility index of more than 95th, our fetal medicine colleagues tend to call it the early ductus venosus changes, and the late changes or the absent A wave or the reversal of the A wave sparks a lot of anxiety. So the late changes probably predate fetal death by about a week's time is what is said. So in this study, they looked at the qualitative venous Doppler waveform in preterm IUGR fetuses with absent or reversed end diastolic flow and correlated it with short-term outcomes. So they had 74 fetuses with IUGR and AREDF in the umbilical artery between 24 and 34 weeks of gestation who were born before 34 weeks. What they concluded is that the abnormal ductus venosus Doppler waveforms together with gestational age at delivery showed the strongest association with perinatal death, whereas only gestational age was a marker of neonatal mortality. So once again, it is a good predictor of perinatal mortality. Is it a marker for neonatal mortality? We do not know. So as you can see here, the total deaths, stillbirths, perinatal deaths significantly increased in the group with the absent or reversed ductus venosus flow. Once again, the same question. We are back to the same question. What do abnormal Dopplers mean for us? Do they mean something additional in addition to the prematurity and the IUGR, which is adding on to morbidity? So let's talk about necrotizing enterocolitis. As neonatologists, we are very interested in how our babies will tolerate feeds. And whenever the obstetrician tells us that the Dopplers are abnormal, that is probably the first thing that we are concerned about. So why we worry about NEC in IUGR infants is because of the steal that happens from the splanchnic circulation. There is redistribution of blood flow more towards the brain. And this redistribution probably causes chronic hypoxia of the intestine. Probably there are studies to indicate, animal studies to indicate that this probably affects the motor, immune as well as secretory function of the intestine in later life for these newborns. There's also some component of pseudo-obstruction that happens in babies with IUGR, where the intestine doesn't move along as well as we would have liked it to. So in terms of splanchnic circulation, there is some interesting data. Postnatal physiological studies have shown that there are persistent abnormalities in the superior mesenteric artery in infants who experienced absent or reversed end diastolic flow. Both SMA and celiac axis blood flow velocity is reduced on the first day of postnatal life, and it probably takes about 4 days to 7 days for the blood flow to go back to normal. Although the blood flow does go back to normal, as when I say normal, when compared to a term neonate with absolutely no insult in utero, the dynamic response to enteral feeding, because feeding itself increases the oxygen requirements of the intestine, the dynamic response of the intestine to feeding is probably still impaired. So in this, there are 14 studies that they looked at here, looking at NEC incidence among preterm growth restricted infants with abnormal antenatal Doppler results. There was an overall, there are 14 studies here, 9 of them showed an increased incidence of NEC among AREDF infants, preterm infants who had AREDF or absent or reversed end diastolic flow as fetuses. There was an overall increase with an odds ratio of 2.13. So they are at increased risk of NEC as per this meta-analysis here. Once again, prematurity is something we bear in mind. Again, another study which looked at association between abnormal antenatal Dopplers, gastrointestinal outcomes in preterm infants. They had 570 neonates here who were delivered before 32 weeks of gestation, and they looked at 3 categories of umbilical arterial Doppler abnormalities. One is the AREDF, absent or reversed end diastolic flow, absent or reversed end diastolic flow plus ductus venosus changes, and finally the controls. As you can see here, all the GI morbidity is higher in the groups with the absent or reversed end diastolic flow, and also those with AREDF plus ductus venosus. So feed intolerance, any stage NEC, spontaneous intestinal perforation, time to and the length of hospitalization, all were significantly increased in these groups, all of which are of interest to us as neonatologists. So looking at the ADEPT trial, which was published in 2010, they looked at 404 preterm growth restricted infants with abnormal antenatal Dopplers, that is absent, and again, most of these studies are looking at umbilical artery Dopplers, and when I say abnormal, they are looking at AREDF or absent or reversed end diastolic flow. The number of episodes of all-stage NEC was significantly increased. They had 2 arms in the study, a slow feeding and a fast feeding arm. The incidence of all-stage NEC was significantly increased in both groups. So there was no difference between the early and the late feeding groups. However, the incidence itself was significantly increased, probably saying that the very presence of AREDF puts them at increased risk of NEC. All adverse gastrointestinal outcomes significantly were more likely in the less 29 weeks infants, so prematurity is also playing its part here. The only factor was protective, as we always say, breast milk. Breast milk was the only protective factor. So again, another study which looked at predictors of necrotizing enterocolitis. They had 404 infants, of which 39 experienced NEC. NEC cases all had abnormal umbilical artery Dopplers compared to the controls. Moving on to the neurological outcomes, which is of significant interest to us. My colleagues have already talked about how IUGR infants themselves are at risk of adverse neurodevelopmental outcomes. So we are looking at the cerebral redistribution. We have always said cerebral redistribution is a protective phenomena. Lately, there is literature that is questioning this concept. Is cerebral redistribution really protective? Okay, so we are moving on. The parameters that we monitor in terms of Doppler are probably signs of worsening fetal status and are probably a tip of the iceberg. So they're probably underlying changes that continue to happen for a long period of time, exposing the infant to chronic hypoxia and probably causing significant amount of vascular remodeling in a number of organ systems. So once again, this entire concept of cerebral redistribution being protective is now being questioned. There are regional changes in blood flow that begin very early. Apparently in the anterior cerebral artery, the changes can be seen much earlier because the blood flow to the frontal zones, which control our higher mental functions, are initially increased when the fetal deterioration begins. Once the fetal deterioration worsens, then the higher mental functions are no longer a priority. Then the blood is being shunted to the basal ganglia. So that's when you'll start seeing changes in your MCA. And with further deterioration, the blood flow is now shunted to my brainstem functions because survival is most important. So there are regional changes in blood flow that are probably happening. Does this cause pruning? Does this cause changes in cerebral architecture? Does this cause vascular remodeling? Are these babies at increased risk of stroke in the future? This is all being questioned in latest literature. And the interesting bit is that these changes are probably persisting after birth. So they do have implications for us as neonatologists. So in this study, where they looked at the impact of cerebral redistribution on neurodevelopmental outcomes in SGA infants, growth-restricted babies, it's a systematic review which included 9 studies and 1198 fetuses. Both term and preterm populations were included. Very heterogeneous study population here. But what they did use as a marker of cerebral redistribution was an MCA PI of less than 5th centile or a CPR ratio of less than 1, as my obstetric colleagues have been talking about. What was of interest here is they were trying to look at whether the IVH incidence was different. The IVH incidence was not different in this meta-analysis. What was different was the fact that the cerebral redistribution was associated with increased risk of severe periventricular echo densities, associated with lower scores in motor development, motor function, and increased risk of adverse neurodevelopmental outcomes. So is cerebral redistribution, again, the same question. Cerebral redistribution is probably not protective, or it is a marker, it is a very good marker of fetal acidemia and poor neurodevelopmental outcomes in the future. Again, truffle study, which Dr. Deepthi also referred to. Here they looked at the 503 eligible women were randomly allocated to CTG monitoring, ductus venosus P95, more than 95th centile, and ductus venosus with absent A wave. And the median gestational age at delivery was not different here. It was almost same amongst groups. Of the survivors, more infants where women were randomly assigned to delivery according to late ductus changes were free of neuro impairment at 2 years of age. So is the ductus venosus, this probably goes on to say that the ductus venosus changes are a better marker than CTG alone. So that is what you're seeing here. Survivors without impairment was significantly more in the arm where ductus venosus was used as a marker for delivery. So there is a whole body of literature which goes on to say that abnormal Dopplers do predict worse neurodevelopmental outcomes, which we do not really discuss much in detail with our parents, but there is significant amount of evidence which is now gathering or has already accumulated, where all this here, right? I'll just quickly go through. Umbilical artery AREDV is a marker of lower motor developmental index at 2 years, lower cognitive performance thereafter. ARED survivors have twice the risk of major neurological sequelae, 10% higher risk of minor sequelae. At age 6 years, fine motor and gross motor skills are significantly lower. Reversed end diastolic velocity is probably an independent risk factor for adverse motor and cognitive development all the way extending up till adolescence. So this is once again something for us to bear in mind, that the Dopplers are probably signaling later life poor outcomes as well. So in summary, antenatal Doppler abnormalities are being used as a marker of fetal compromise and perinatal mortality in order to reduce perinatal mortality. Neonatal morbidity is significantly higher amongst the babies who have abnormal Dopplers, but it is influenced by greater degrees of prematurity that we are seeing in these groups. The abnormal fetal circulation can persist into early neonatal period, probably into late neonatal period. What are the implications of this? We do not yet very clearly know. GI morbidity is significantly increased in fetuses, IUGR fetuses itself, and IUGR fetuses with abnormal Dopplers all the more so. Long-term neurological outcomes may be influenced by severity of fetal hypoxia and acidemia, as indicated by our cerebral redistribution parameters. Thank you.
Thank you, Dr. Tejal, for such a wonderful talk on a difficult topic. If you have any questions, I would like to take up.
Excuse me, I'm Dr. Leela. I would ask you a question. You said that maternal mother's milk decreases necrotizing enterocolitis. How?
One more line.
In my slide, what I was referring to. Ma'am, in my slide, what I was referring to was the results from the ADAPT trial. What they found was that babies who had reached about 50% of feed volume with mother's milk before the onset of symptoms, they had lesser risk of NEC. That's what. But there are a lot of trophic factors inside breast milk which promote intestinal, better hormonal secretion, motility that do prevent NEC.
One more question is, they said that there was a comment made saying the baby's mouth should be smeared with colostrum. Can you give me a little more detail about that?
Yeah, ma'am. So we do a lot of, we believe in doing minimal enteral nutrition. So the earliest that you can do that is by doing, we do smearing of breast milk into the baby's mouth. Once again, the goal is the same. Maternal, maternal flora, colonizing the baby with maternal flora, inducing the secretion of hormones, intestinal hormones that promote motility, secretion. It's much better when breast milk colonizes the gut before we introduce anything else.
So that you are advising that to be done immediately after?
We are doing that, ma'am.
We are now going to start the panel discussion, which is the final program for this event. Lunch will be served from 1:15 onwards. The door, the end will be open. So people who are hungry and they can start taking the plates and coming in, but make as minimal noise as possible. The others can all join us for the lunch after the panel.
Start, Mali.
We have a panel on growth restriction. We have taken two cases, important cases which have been managed very well by the neonatal team. We have as Dr. Srinath Manikanti, who is the head of our neonatal team, will be moderating the session, along with one of the fetal medicine consultant, either I and for one case and Deepthi for the other case. Yes, Dr. Srinath, now you can introduce your panelists.
I think this mic is working. Hello.
Wants to be smarter.
Yeah, we have come to the end of the program. This is the most awaited one, the panel discussion. We have eminent panelists from obs and gynae as well as neonatology. To start, I would like to invite Dr. Lata Venkatram on the stage. Next slide, please. So Dr. Lata Venkatram doesn't need any introduction, and she is the Director of Women and Health Care and lead consultant in Langadurai, and she's a panelist in many forms. And next I would like to invite Dr. Malini. She is a senior consultant and professor, Department of Obstetrics and Gynecology in SIMS and RC. Next I would like to invite Dr. Sushila Rani, Director and Consultant, Obs and Gynae, Manjushri Specialty Hospital. Now from the neonatology side, I would like to invite Dr. Suman Rao. She is the professor and head of the Department of Neonatology at St. John's. She carries with her a vast experience both in clinical as well as in research. And I would like to invite my dear friend Dr. Praveen Venkatagiri. He is the head of the Department of Neonatology at Chinmay Hospital. Apart from being a neonatologist, he is an entrepreneur as well. And Dr. Vishwanath Kamoji, another dear friend of mine, is a lead consultant neonatologist from Manipal Hospital. And we also have Dr. Deepthi, our dynamic fetal medicine consultant, to assist in complicated questions. Okay, so the screen is visible. Maybe I'll come this side, okay, because they'll be able to see. Yeah. So to start with, okay, I have that. So what are the objectives of this session? So to give an overview of the course of FGR babies during pregnancy, and also to discuss the acceptable evidence-based practices, and so to discuss about the challenges in dealing with FGR babies in the NICU, and what are the strategies that we do to overcome these challenges, and examples of best possible outcomes. So they come in different sizes, as you see that, the fetuses, but every fetus has a potential to grow. So the failure to achieve growth potential is called as fetal growth restriction. So we are going to discuss two challenging cases that with the help of our fetal medicine and very good obstetric team, we were able to give excellent outcome. I would like to invite Dr. Chitra Ganesh to take up the first case and start the discussion.
Yeah, start. Next. Sorry. This was a case of a preemie 31-year-old, non-consanguineous marriage with regular cycles once in 30 to 35 days. Dating scan was done outside and it was corrected as per the CRL, so we know the age of the baby. It was referred to our unit at 21 weeks with a suspicion of a growth restriction. The wife had the O negative blood and husband was O positive, so she also had an RH status with her. Her aneuploidy screen, which was done at 11 to 14 weeks, was normal or low risk. So this was the scan which was done by us. So what is your inference from this scan, Dr. Sushila?
Thank you, Chitra. I get to see that amongst the various parameters of biometry, the biparietal diameter is on the 5th centile, the head circumference is on the 19th centile, and all the other parameters seem to be okay, except for the fact that the biparietal diameter is in the 5th centile, which is something that can cause a little concern. But as of now, I would say that this baby needs observation, continued follow-up, and close monitoring, especially with reference to the BPD. Other than that, nothing.
Okay, the mother
It could be a small head, for all you know. Some babies do have a smaller biparietal diameter and continue to grow normally and absolutely no problem. So I would like to keep a watch on this baby, but as of now, nothing.
Yes, the mother is about 4 feet 11 inches.
Yeah, maybe it could be a constitutionally small.
Yes. Dr. Malini, are you also wanting to keep this baby under surveillance? You don't feel something is wrong?
Yeah, no. Definitely, I'll keep the baby under surveillance because, of course, all the parameters are within normal range. It doesn't fit into the definition of FGR rather. But what I'm worried is this dolichocephaly thing. You know, is it significant? I really don't know.
Dolichocephalic is the least thing we are worried about, actually, because it only reflects the shape of the head. Some people will have elongated, some people have round. If BPD comes like this, we disregard BPD in assigning the gestational age, we only take the HC. Yes, this baby was on the lower percentile of growth, but was still normal. So,
did she have a previous scan, Chitra?
She had a dating scan. She also had an
12-week scan.
12-week scan also was normal, which was going. Only at 20 weeks, she came to us around 21 weeks.
What about the uterine artery Doppler?
Yes. See, this was the uterine artery Doppler in her. So, how do you interpret the?
Yeah, that is at 22 weeks.
Yes.
Yeah, there is, yes.
At the time of scan.
I mean, above 95th centile, so it is uterine artery PI is high. So there could be evolving growth restriction, early onset growth restriction, but I would like to have a few other parameters.
Like?
Okay. What is AFI, appearance of the placenta, and also whether the fetus is already redistributing itself, its Dopplers, what are the fetal Dopplers?
Since
placental morphology, amniotic fluid, and also the Dopplers.
Okay.
Fetal Dopplers.
Yes, this one was only about 21 weeks, 2 days. Her uterine artery was high resistance. So we calculate the mean uterine artery, PI and mean uterine artery was 99 percentile. So she was screen positive for PIH and FGR. As of now, she has not become FGR, but she is screen positive. Just like how we have an aneuploid is screening positive, this one is screen positive for PIH. So we only do the surveillance and further follow-up. Placenta at this point looks normal. Since there was no IUGR, we have not done the umbilical artery at all. And Liker appeared normal at this period.
Fine.
She hasn't gone into IUGR as of now.
What's the blood pressure, mean arterial pressure at this point of time?
Her mother's blood pressure was normal at this point.
Yeah. See, all that we can say from this is, this woman is at, this fetus is at risk for FGR.
Yes.
As of now, there is no evidence to show of it, but it is at risk of FGR.
She is at risk.
And mother for
risk for PIH. Okay. So she was suggested rescan after 4 weeks. And this is the second visit, which was after 4 weeks, 25 weeks, 2 days. Now, what is your interpretation?
So the BPD continues to be low only, but what is striking is the abdominal circumference. There is a growth lag definitely by almost 4 weeks when AC is concerned. Other parameters, there is a growth lag by 2 weeks. And EFW is less than second percentile. Okay. So definitely this will fit into, if you take the Delphin criteria, it will fit into the early onset FGR. Yeah.
Yes, it is early on. Suppose if the patient had come to us for the first visit at this point, 25 weeks, and this is how she is presenting, one of our thought process will be whether it is wrong dates, because all the parameters are falling short. That is why we do the TCT, the cerebellar diameter we measure to find out whether the gestational age of the baby is normal. So now we know definitely this baby has become almost a symmetric IUGR. All the parameters are below the less than the 10th centile, and the fetal weight is also very low, less than the 3rd centile. And now that the baby has already gone into fetal restriction,
definitely
growth
we would
restriction,
like to go for umbilical artery Doppler.
Yes. Yeah. MCA was also done. The percentile was not, it had not come into this slot. But MCA, so definitely you find...
there is, umbilical artery pulsatility index is more than 95th centile. So if you take that Grataco's classification, FGR with the it shall come in stage 1.
Stage 1.
Because placental insufficiency, definitely.
So ductus venosus at this point was looking normal.
Yeah, it is normal.
Yes, Dipti. Now, how will you report it, and when do you want to see the patient again?
So it's a case of a stage 1 intrauterine growth restriction presenting early. It's an early onset intrauterine growth restriction at 25 weeks. And the ductus venosus being normal at this point tells me that it is a stage 1 case. And I would like to see this baby every 1 to 2 weeks. So I'll call her probably in 10 days to 2 weeks.
Yes, she is stage 1, so weekly monitoring. Probably because she's only 21 to 25 weeks. Yeah. See, even in Grataco's theory, Grataco's classification, what he says is, if the fetus presents to you less than 28 weeks, it is important that you counsel the parent that prognosis may not be very good. So at that point, weekly monitoring may not help you much, because even at 26 weeks something happens, you are not anyway going to, salvageability will be very less. So would you like to refer for a neonatal counseling at this point itself, or would you want to wait for the next scan?
I would like to wait for the next scan probably, because yes, we are heading that way, but there is nothing acute. I haven't even thought about steroiding the lady. So when I probably decide to steroid, then I would probably ask my neonatal colleagues to see, rather than just getting the couple more and more worried. So, and also 25 weeks, it depends on your unit protocol. about the viability, the limits of viability, what your unit protocols are. So 25 weeks might still be low. We usually think about 26 weeks. But no harm steroiding her, not now really. So we would like to keep a closer watch on this lady.
So you would like to wait for one more week?
Yeah. For blood pressure. They might simultaneously develop preeclampsia also. So I would like to wait for one more week before I refer her on to the neonatal clinics.
My question to you, when do you steroid? What is the earliest gestational age when you can give steroids?
Depends again on the unit protocol, what the perinatal team, we have agreed upon. Usually in our hospital, Rangadore, we tend to steroid them by 25 weeks if we are anticipating delivery by a week or 10 days. So that is when we tend to steroid. Earlier than that, we are not very comfortable. Thanks.
So this was an early onset IUGR. Liker activity was normal at this point. Your ductus was also normal. Umbilical artery was showing a few loops absent in diastolic. We did not know whether it is to be reported or what, since we were anyway managing on serial scans in her. We decided to do the next scan.
Sorry, can I ask a question? It's a reverse panel probably. Okay, right. We know that there is likely to be a placental pathology here. But in spite of that, with early onset IUGR, what is the latest recommendation on checking for chromosomes?
We know this.
Microarray or chromosome, whatever.
Yeah.
Investigations.
We know this baby, when we are following it from the beginning, it had a normal dating scan, was normal at till about 20-21 weeks, and only at 25 weeks started showing growth restriction. And we know the placenta was at fault right from the beginning. And there are no other markers of aneuploidy or aneuploidy risk for the major 3 chromosomes. We do not think about Down syndrome when FGR comes, but our main concern is whether it is triploidy or whether there is any translocation deletion problems which can. This ultrasound wise, it did not show any structural malformation which were in the process. If we have a symmetric IUGR before 20 weeks, then it is irrespective of whatever it is, we do all the investigations, including infection, screening, including aneuploidy, etc. So,
because some of the aneuploidies, triploidy, etc., can present with placental pathology also, is what the latest.
Placentitis is one of the common cause for.
So, whether we should screen them.
See, we are already reached 25 weeks. We have already reached 25 weeks at this point.
In this case, there were no other markers for us to
but
suspect
placental mosaicism is one of the things that can cause
because
FGR. I just wondered about
No.
Because let's not confuse the issue.
It's not. The thing is, the commoner things first.
Yes.
So once we know that this has a placental background, then
it's highly unlikely that it would be a chromosomal problem.
Unlikely to be.
Have undergone this biochemical markers and that.
That's for T21, 18, 13. If at all some IUGR has to happen, it can happen in 18, which itself will show multiple ultrasound findings. So we didn't think on that line. We are more in favor of placenta, and when umbilical artery also started showing abnormality, we are more in favor of placental rather than aneuploidy as a cause for IUGR. So this mean cerebral artery PSV was measured and it was found to be at 1.25. Now, why did we do this, and what is your comment on this?
Okay. So this was an Rh negative pregnancy with a spouse being Rh positive. So to identify fetal anemia, in all cases, generally we start doing middle cerebral artery peak systolic velocity right from 20 weeks. And when this peak systolic velocity is more than 1.5 multiples of median, then we would say there is a chance for a severe fetal anemia. And when it is less, then we will just keep following as in any other case. And in this case, it was around 1.2 mom, and it was within normal limits.
Just one question. ICT was negative, right?
ICT was.
Still you will monitor at 20th week itself?
Yeah.
Even when the ICT is...
No, I thought it is ICT positive and look at the dilution and then monitor.
No.
complete length,
MCA
because now we know it is a sensitized pregnancy, right?
How do you know it is a
It's not sensitized.
This ICT was done, it was negative. But even when the ICT is negative, we routinely do an MCA PSV in her routine visits. We don't call her for this, but in her routine visits at anomaly, we do an MCA PSV.
At 20 weeks onwards. So that is more important, yeah.
No, this fall in the MCA PSV, you think it is due to sensitization?
No.
It is not.
No. It is
That's what
at
I'm saying.
1.21.
You were saying about sensitization.
I'm telling about ICT.
I see.
That's also my question, because I do not think babies go into isoimmunization without ICT being positive. So my call would be to do repeated ICTs, because during pregnancy you can have sensitization, and once ICT is positive you can decide what is the titer you want to start screening for fetal anemia by MCA. Without ICT positivity, I'm not sure that there's any role for MCA PSV monitoring in RH isoimmunization.
No.
I mean, I don't know, if you check the PSV at this stage and you present a history of RH negative, it tends to confuse the picture.
No. This is basically to understand. ICT you do at booking.
Yeah. And we do it again. We repeat it.
We do it at 28 weeks next month.
Yeah.
Sorry, I would support Chitra's management here.
No.
Because ICT can be negative initially, and later on they can get sensitized. You are not doing ICTs every 4 weeks, isn't it? So routinely looking at MCA PSV once is fine actually. I have been caught unaware at 32 weeks.
We have picked up RH
I have
picked
been
up
caught unaware.
fetal anemia even when she had an ICT done at 8 weeks when it was negative.
When
so
she
it
was
is
done at
not
booking.
wrong to call it. We are not calling the patient for an MCA PSV, but we are doing it under routine anomalies.
That's right. Even when it was negative at 24 weeks, I was caught unaware at 32 weeks because there was some reason fetal-maternal hemorrhage had happened. So probably it's a good practice to look at MCA PSV. Again, at 32 weeks again, if you have not done it more recently than 16 weeks.
Where you are doing the fetal down.
The routine monitoring in RH is at 28 weeks, you will repeat, because if ICT is negative, that's the time when you can plan for antenatal anti-D. Okay, so you will repeat at 28 weeks.
Maybe I would like to take this forum to request obstetricians to give anti-D for ICT negative RH immunization at 28 weeks. Because that really reduces your isoimmunization by more than 50%, because we don't see this commonly. We are still seeing connectors in RH isoimmunization, unfortunately.
Yes, we have.
The protocol is that at booking, if the ICT is negative, you repeat it 28 weeks and then give anti-D. I think all of us are giving anti-D. Maybe you must have picked up the
peripheries.
No, we had one patient last week who had an ICT which was negative, but as you say, the frequency at which it is done versus the anti-D when it is given varies. It
And
still is
also
not
minor antibodies might not be picked up. Okay, that is another
And-
problem. Depends on the reagent. There are so many factors. Let's not open the Pandora's
just
box.
like-
we will get on with IUG.
No, just like how polyhydramnios, many a times we pick up GDM with polyhydramnios,
That's
though
right.
you have done your screening test earlier. Okay.
Yes.
So when do you want to rescan the patient? Now she is umbilical artery positive.
For 2 weeks, 2 weeks later we'll call her.
Yeah, high resistance flow.
1 week, I think, because she is already in stage 1, there is placental dysfunction.
No, we can do
So I
weekly
think
monitoring, but only thing which was because it was 25 weeks plus.
She was only 25 weeks. So even if we pick up something at 26 weeks, we are not. The management is not going to differ
You know
much.
what?
So we'll call
Intermittently
her
absent. Here
No,
and
we
there.
did actually weekly monitoring.
That is the problem.
And at 28 weeks, these were the findings. So now you are very convinced about absent diastolic flow. There are a few cycles showing reversal of flow also. And the ductus was still normal. and MCA PI was. So the growth chart, when you see, definitely this baby had an downward trend in growth, so it was growth restricted. And the Doppler chart, as you see, the first from the umbilical artery was high resistant right from the beginning. Right from the beginning. Yeah. The MCA was redistributing, and in the final scan when we did, MCA tend to come to normal, and your ductus venosus has started increasing. So the fact that MCA, which was showing a redistribution, now comes up to normal itself is an ominous sign. So it is a sign that there is a cerebral edema which is compressing the vessel, so the resistance in MCA is increasing. So this is not a reassuring sign. So that is when we thought we will take her up. Now, decision to deliver, Dr. Ritu.
Can I just say?
Yeah.
With increased DVPI, you have taken her up for delivery. Usually, most of the chance is SWOG, graticose, etc. Yeah, reversal, isn't it?
No, that depends on
might have got a couple of days.
That depends on your NICU. You don't want to give them, if they are capable of managing a 28-weeker with a forward flow in DV, instead of reversal, we would prefer, because everything depends on...
Maturity also matters, every day is important. So, I mean, according to the data presented, AEDF also has...
Yeah, this data presented by her is now new to us now.
Yes, quite
now we
very
have to go back.
isn't it?
Maybe.
So, you want to deliver them earlier and earlier rather than waiting for
no,
maturity.
The way that the baby has developed cerebral edema.
That question has to be answered by neonatologists.
The problem now we are looking at is whether we would have the baby deliver now, go to the NICU and die there, or wait for some more time and have a more survivable baby. Maybe with some morbidity.
So we have our obstetrician, Dr. Ritu, who managed this case. Now, Ritu, tell about the steroid, what you did for this baby, and when did you give Maxelf, and...
So first thing to start, hi everyone. So first thing, what to take care is maintain the uteroplacental flow and then maintain the fetoplacental flow. So we all know that we start with ecosprin and we start with enoxaparin. And the one thing that I would like to mention is that increase the doses as the mother increases the weight. That is the common mistake we do, that we put them on 40 milligram and then we don't increase the doses because we have to keep on monitoring the weight of the mother. The moment she crosses 65 kgs, we should increase it to 60 milligram. And the second thing is that start the vasodilator sildenafil. That is a normal thing. 25 milligram BD I have put the patient on, and the RG prick that usually we are using, and the steroid with 2 doses, and if it is more than a week, give them a rescue dose. And I have put them on Maxelf citrate, 200 milligram, which is, I don't know, it was under studies and I have read few articles. And I started when the hypoxia insult started in my patient very early, at 20 weeks. So 250 milligram of Maxelf, I started the oral dose every day. And after admission, when we decided to deliver, when I discussed with Chitra madam that the patient, the umbilical artery flow is not there. So we thought, because it was a monochorionic diamniotic twin. So
this is the Harika.
This is Harika, okay. So we had 2 cases, similar cases. One was twin and the other was then we steroided her 2 doses and we gave her for neuroprotection Maxelf, and after 24 hours we delivered.
Sorry, can I beg to disagree with you regarding the administration of LMWH? When there is already a placental pathology, established placental pathology that you have recognized only at 22 weeks, when the trophoblastic invasion have taken place, there is no evidence to say that LMWH would help. Even your aspirin, which is non-harmful, will help. So so I would like to disagree there. And also magnesium sulfate oral tablets, there is no evidence again. And it is, if at all, IV magnesium sulfate, the same regime as eclampsia regime, we have to take at least 4 hours prior to should be started and continued till you deliver. And
if you plan delivery within 24 hours, then will be helpful.
That's right. That's right. But at least 4 hours prior to you should have started. Otherwise, it is of limited value. That's what they say. And yeah, okay. Emergency section. Okay, fine. Yeah.
I can't understand the basis of giving low molecular weight heparin.
No,
here.
ma'am, I
Not
thought
for
it
this
is the
case.
twin pregnancy.
Not
It was for the
this
separate
case.
case.
She
So
had
you
thought it
didn't
was
give low
Harika.
molecular.
No,
see,
not for her.
Not for
No,
her.
it was given for the other case, the second case that we are going to
Which was
discuss.
Then, okay, fine. Then we can understand. If it is not for this case, because giving low molecular weight heparin in this kind of a situation is not going to be helpful.
No,
in
this
any
was a
which way.
different case.
The only thing that I would consider giving is steroid and magnesium sulfate. Magnesium sulfate if I am going to deliver the baby within the next 24 hours. And steroid, yes. Are we going to wait after giving steroids for the next 24 to 48 hours for the steroids to act and then deliver? Or are we going to deliver immediately after giving steroids when it may not be all that effective? Is one thing that we need to consider. Magnesium sulfate, if you're planning
4 hours
delivery,
before.
yes.
No, that's what they did for this case. It was given just as soon as the report went.
For steroids is my humble submission, because if you are, it is DVPI, increased resistance. So you can even repeat the Doppler in 12 hours if you want to. And if you had the facility for STV, that is the computerized CTG, it would add on value. The latest CTG machines are coming with CCTGs. So I think we should.
So this patient, when we were on the process of monitoring, when the umbilical started reversing and we with few loops showing absent diastole, that was about 4-5 days before only steroid was given. And magnesium sulfate, yes, as soon as the report went, she gave. By the time we started getting everything ready, it was just 4-5 hours before that. And then it continued.
Fair enough, I suppose.
Continued.
Just to reiterate the need for steroids, our request is to make sure you try to give a complete course as much as possible. Here you had a window of around almost 4 weeks, 28 to 32. We are saying absent diastolic flow reversal. You can wait around 32. So I think when you get to absent reversal, it's a good time to give steroids so that you complete the course, because for us, it makes a huge difference. And it's not only about survival, it's about every organ is going to benefit from steroids. And that's why please make sure that you complete the course for steroids and don't just give it and deliver the baby.
No, that's what even our neonatologist says. Steroided babies are better off rather than unsteroided one. And most of these patients whom we are monitoring on a regular basis, presuming that they will deliver as early as possible, steroids are given. And
optimal timing of steroids is also very, very important, because we don't want repeated doses of steroids in this particular situation where already you might have problems, cerebral problems, so that will steroids, repeated doses can add on to the coverage.
This baby required only one dose. That means at 12-hourly interval, and max self was 4 hours before, and a female baby of about 650 grams was given, and now NICU took charge. Now for the neonatologist, yes, yes, sir.
Absent and diastolic
No,
flow,
this became reversal also.
This became
Reversal with
reversal.
ductus showing change and MCA becoming decompensated. So is there a relevance for you about this antenatal Doppler at all? See, for neonatologists.
Ask question again, please.
Is antenatal Doppler monitoring relevant to you at all for postnatal management?
A lot of relevance.
So which is the Doppler which you rely mostly on?
We rely basically on umbilical artery and the MCAs.
Yes, sir.
Some units do DVs, but not many units do DVs. You agree?
Because many a times we think whether we are struggling with antenatal Dopplers, whether the neonatologists look into the picture at all. That is, once a baby is on hand, I don't know. That's why I wanted to ask.
Umbilical artery and the MCAs.
Yeah, thank you so much, sir. Now, Dr. Our neonatologist will check.
One question, sir. With respect to the umbilical Doppler, what is the thing that matters to you the most?
This is
good. But this, regarding about Dopplers mean a world to us, even in places where we don't have fetal medicine experts. Sometimes it's the neonatal people who sort of counsel to decide on time of delivery. And there, we are requesting our obstetric colleagues to look at ductus venosus to push the delivery to as long as it is possible to, because for us, even one single extra day in utero improves outcomes by 1 to 3%. And that's a huge thing. So please monitor ductus venosus and don't try to deliver early even if you have the best NICU. It makes a difference.
Yeah, I agree with you. It makes a world of difference.
Every day, I think 3 days less in
in utero is 3% survival rate. Yeah, that's what increases the.
So that is what Gratakos says very clearly. So if you have these findings, don't worry about how many days it is going to stay inside or outside. The best outcome is when you do this, when you deliver it at this period, depending on your Doppler. So earlier, when the moment we say absent diastole, enough FGR fetus, people used to deliver. So now that concept has gone. We can wait till reversal, we can wait till ductus, but still, how long should you wait for the ductus to reverse before you deliver? Depends on the gestational age of the fetus also.
That's right. And every day, as she said, matters. And yeah, I mean,
No.
by 20, actually, ISWAG is more liberal with gestational age, which is good. Actually,
No,
you
Simar
can
and,
go up to 30 weeks, even with ductus, with ISWAG.
Yeah. See, after this came, Simar in Cochin and our Manipal Hospital, Bangalore Airport Road, they are following this regime and they are very happy. They have not had any problems because they know what to do when. And of course, Gratakoska.
This is
Gratakoska.
But ISWAG is more liberal with gestational age.
No, that's what the protocols are so many. We just stick to one and we stick to this one and follow.
What you are comfortable with is what is more important.
That's more.
Because there is always this fear that you might lose the baby while waiting.
Yes,
so you can say, okay, ISWAG says wait till 30 weeks, but what if I lose the baby in between?
That way, anytime.
A very interesting discussion. Yes. Fantastic. And now it's time for action. We have been waiting for. And we can't agree with you more about anti-allelic steroids and magnesium sulfate. It makes a lot of difference for these babies. And majority of our good neonatal outcomes are because of expert handling by obstetrics and as well as fetal medicine. So this baby delivered via emergency C-section at 28 weeks and had a weak cry and poor respiratory efforts. So had to be intubated, although we predominantly do non-invasive ventilation in our unit, but this baby had to be intubated and transferred to NICU on the ventilator, on the transport ventilator. And baby is a 650 grammer, it comes to 3rd to 10th centile in the Fenton growth chart, and put on minimal ventilation and needing about 40% of FiO2, and blood gas shows uncompensated respiratory acidosis, and first dose of Curacif was given. And USC, UVC are in C2, and it shows a mean BP of 22-24, which is slightly less than what we expect for this baby at this gestation. So started on TPN and IV fluids and also started on dobutamine. So first question to Dr. Suman. So we have a very preterm baby, ELBW, IUGR, and having RDS and hypertension. So what would you counsel these parents?
Yeah, so first of all, as far as this baby is concerned, we would be involved with the parents even before delivery. Absolutely. We encourage antenatal counseling, and we are part of the team who decide when the baby should be delivered. So we have already told them a few things. And when the baby comes out, I don't feel that's the time that we need to discuss all the problems that we relate. Okay. So when they come to us, we are looking at, like you said, time for action. We are also telling the parents it's time for action. What should they do? That's most important than knowing about all the problems. What they need to know, their baby is small, their baby is born early and born small. And that's a double jeopardy. And every organ is immature and every organ needs support. It's not only about ventilator, breathing. And there is the concept, unfortunately, even today among pediatricians and neonatologists, that if you're IUGR, your lungs are more mature. RDS is lesser. That's a wrong concept, and it's been a wrong concept for the past 20 years. But even now I hear people talking about, oh, the baby will have less RDS. That's not true. And you see there, you have a white out lung there. So this baby has major issues, but We have great outcomes even in such babies. So what we do is we tell them there is a problem, but not dwell on it. We don't generally talk too much of neurodevelopmental, long-term DOHAD and all that right away. Not at all. We say this baby is now on ventilator. The first 2-3 days is critical. We need to get the baby off the ventilator as soon as possible. We need to talk about feeds. So when I said action, what do I want the mom to do? First day, oral application of colostrum is needed, and we now try to make sure that when baby is shifted, either the baby is already smeared or the colostrum comes in a syringe. Don't try to express it in a cup, express it in a 1 cc syringe and get it. And we start doing kangaroo mother care and talking about it right from the beginning, even for such small babies. And we do it for ventilated babies. So our issue is about what can the family do. The kind of family we get, we also have to unfortunately talk about cost, because NICU costs are huge and families need to prepare for it. And we also explore whether they can have any of these government schemes which are now available for the babies. These are our first day counseling, identifying a surrogate or a person who will be with the baby. Ours is an open NICU. We encourage fathers and mothers, and in addition for kangaroo mother care, other families, and we tell them what needs to be done rather than questions on survival, percentage. If they ask us, we are honest. 28 weeks, our survival is around 70%. But this baby is also IUGR, and that makes a difference. But what we need to highlight is there is a lot of hope for babies because they have a lot of chance, what is called as plasticity, not only in the rest of their body, but mainly in the brain. So we need to talk about that, because some families, especially the educated ones, are not so bothered about survival. They'll say, okay, if the baby dies, it's okay. But I don't want a baby to survive with morbidity. Correct. And that's something that we have heard so common. But we have no choice. We have to continue to treat. And they ask, the other word we hear is guarantee. Guarantee kortira maguge. So what we say is, we can't give guarantee for anyone, but we can give guarantee of the best care that we can provide to your baby. And with all of us together, you being the main person, the mother being the center of the treating care team, we can give best outcomes.
Fantastic. I would throw a hypothetical question to you. I know it's an emergency C-section. Suppose if I have another couple of hours before the C-section, would you encourage the mother to express colostrum and keep it ready?
Antenatal colostrum, a lot of studies have looked at antenatal expression of breast milk, improving breast milk output subsequently. The studies have been generally in late preterm diabetic mothers, but this is a good thought. We have not yet started it, but yes, mothers can express, and here you're not worried about her going into preterm labor,
yes,
right?
Exactly.
So it would be a good thought to express, and that would also highlight the importance of mother's own milk.
Yeah, Professor Neena Modi from London, she's a strong proponent of antenatal colostrum. Yes. Dr. Praveen, would you like to?
Colostrum, yes, I agree. But how many of them can actually produce even a drop at that point of time? No, I mean, it's nice. The concept is wonderful, but to produce that single drop, drops of colostrum.
At least attempt can be made.
Yeah, attempt can be made. Maybe.
We don't know antenatally. We can say about labor room colostrum. Yes. Colostrum expression is an art. Yeah. And I found this when I was part of the immediate KMC study in Malawi. Malawi is a place with a very strong and on kangaroo mother care and breastfeeding. The attendants who used to help, they used to express almost 2 ml of colostrum from the mother, right at birth. And that's when I started a QI in St. John's, and we completed that. Colostrum expression is possible. You can. That's why I said take a 1 cc syringe. Now, if you take a Palade or a Kotori and you get a few drops, all of us will get discouraged. Take a 1 cc syringe, and when you see something full, you'll get encouraged to do more. So you do get, and we need to do, maybe antenatally, I don't have experience.
No, I'm talking only about antenatal. After delivery, yes,
There is a theoretical possibility that the nipple stimulation can bring in contractions.
Yeah, that's what
what
we said. When you
labor room
planned,
colostrum is probably a better option.
Because
maybe that you said about the syringe, we do for retracted nipple syringing. No, maybe that method you can suck and aspirate and keep. Maybe you'll get more amount of cholesterol.
Okay. Next question to Dr. Vishwanath. So we have this baby. When would you start feeds on this baby? And Dr. Suman has already said the colostrum painting will be.
Suman has actually told. Answered it partly, but to answer in one sentence, it's going to be ASAP. We have hypertension, we have RDS. I don't know what the sugars are in this baby, but baby is needing about 40% oxygen. With that hypertension and being treated, I think it will be reasonable to wait for the cardiovascular stability before we start the baby on some milk. Now, if we get colostrum, then we can smear it in the mouth. It'll be 1 ml, and that can be done immediately. And that is what I would do. I'll start the baby on minimal enteral feeds as soon as possible. As soon as possible, as soon as we get that. And in this IUGR, I'll be hesitant to start any other milk other than mother's milk or a donor milk.
There are a lot of difference in the theory and the practice. Majority of us sometimes keep waiting for the colostrum. How long does it take in your unit to get the first
it takes
colostrum?
a long time, more than 4 hours, I would say.
4 hours is a good time.
More than 4 hours, and you need to go many times to speak to the mother and tell the nurses to help mother to get the express milk.
So, for example, we are not getting colostrum. Okay, they are trying, and the nurses say that we don't get it. So, what are your alternatives? What feeds do you consider?
I would look for donor milk. Now, donor milk is not colostrum. It is a milk which is subsequent to colostrum. So that is the next best milk which I'll get. And I'll probably smear it in the mouth by about 600 grams. So I'll start about 10 ml per kg in a day. So that's going to be 6 ml. So 1 ml every 4 hours. 6 ml will be there. Put it in the mouth. I don't put it in the tube unless the feeds are actually slightly more.
Yeah, that comes to your next question. Are there any contraindications for this trophic feeding?
Other than extreme instability, I will hold off that. Extreme instability is you've got high oxygen requirement, you've got high inotropic requirement. That possibly will scale back on the start of milk or see what is happening to the baby subsequently. Because those babies are much higher risk of bleeds everywhere. You're given a surfactant, the baby may simply bleed from the tube, and baby may also have bleed in the brain.
Yeah, I would, as far as I know, there are no contraindications for trophic feeding. I would like to ask Dr. Suman about this. If a baby is, for example, as cardiovascular instability is there, are there still contraindications for trophic feeding?
Yeah, I like the word which Dr. Vishwanath used, ASAP. That's the thing, but at the same time, MEC is a true problem that we face in these babies. And though we don't want it, we see it. And what we see in Indian babies, we see early NEC. Literature talks about around 32 weeks in the Western world. But in India, in most of the centers, we see early NEC. So we are worried about NEC. In this baby, as long as the baby is on 1 inotrope, I would still give trophic feeding. But once if he goes on to 2 inotropes, then it's a problem. In fact, I was trying to peer at the X-ray that you showed. For me, the heart size in an IUGR baby is very important. And if the heart size is big, that suggests that my baby is going to run into problems. I have to look for pulmonary hemorrhage, other issues. So I couldn't see it because it was white out, but that's one thing I would look out for. And again, this hypotension for me is worrying. But as long as baby is on dobutamine, trophic feeding would go on. And we in our unit, we still use unpasteurized donor human milk from another person, which we just take a consent and we still use it because we think that the benefit is far more than the concern of any other risk.
So you explain the risks and then after that take the consent. Okay. So Dr. Vishwanath, any role of SMA Dopplers?
SMA Dopplers? I don't have a lot of experience with SMA Dopplers, but the SMA Dopplers change with feeding and not just in the preterm babies, but in more mature babies also. And I suspect the SMA Dopplers will reflect what has been happening antenatally with abnormal other arterial Dopplers. So we just take the normal routine precautions and we don't necessarily look for SMA Dopplers once we start the babies on feeding.
Dr. Praveen, what do you think about SMA Dopplers? Do you use them? Are they useful?
Everything is a cycle. We used it, we thrown it out now.
Got it. That answers. Okay, fine. So now comes to day 3. So the baby is still on the ventilator. FiO2 is coming down, but baby requires second dose of surfactant and compensatory respiratory stress and the gas, and BP has improved, and baby is now on 2 inotropes. There are some bilious aspirates, and abdomen is but soft and no tenderness, and there is a neurosonogram that didn't show any IVH. So next question is to Dr. Praveen. So very preterm baby, LBW IGR, and little feed intolerance is there. So how would you proceed? There is a little abdominal distension also is there.
Yeah, I mean, before proceeding on that, so one thing I have to say that it's a little unique in terms of the panel discussion we're having about the case discussion, because it's a real case. And first thing I have to say that I've seen already what you presented, Bhaskar presented, right? The child has gone home, child is doing well, so whatever was done antenatally, intrapartum and postnatally is fantastic, child is safe. So whatever the views that I'm going to be talking about is probably, you know, what in my opinion I would have done, which may or may not be similar. So it's not a comparison of anything. So I just want to make that clear. Okay. So in this case now we're talking about day 3, and the concern here is that as you put it out, very preterm, ALBW, IUGR, these are all the past, and RDS, which is there, which you're treating, and hypotension, but I see that the numbers are good. I'm not sure why we're still on the inotropes. So my first effort would be to look at what are the things that I can remove, right? So the lesser support that I need to give, the better. So what are all the things that I can remove, like in terms of the ventilation, and of course whether we started the milk as we discussed, what milk we started, and the bilious aspirates, that seems to be the main question here.
Yes.
Bilious aspirates doesn't mean NEC. Gut is one of the most important organ, and any or signs or symptoms from the gut doesn't mean it's a gut problem alone. Any system problem can present as a gut problem. Gut problem can present with any symptoms of the body. So we have to look at child as an overall rather than one symptom alone. And most often these babies at this age, the gut motility, especially the upper gut motility as well, will be delayed, as well as the lower as well. So majority of the times it's a dysmotility which is a problem, and that needs to be looked at, whether that is the cause. You would continue trophic feeds, and you're looking at whether any sepsis, other parameters which you have shown there are normal. Abdominal X-ray, you give it to 10 people, they'll give 10 views on that. There is no gold standard to diagnose unless it is, frank soap bubble appearance or perforation like that. So yes, you do it because you keep seeing the changes from one X-ray to another. So basically, I'm not worried about the gut at this point of time. You're closely monitoring. You would continue the trophic feeds, especially with mother's milk. By this time, you should have established that.
Yeah, that's what we did. Actually, we started coming down on the inotropes and then continued feeds. Okay. So how do you increment feeds? Okay, suppose you imagine that in next 24 hours we are coming down on the inotropes and baby is doing well. So how would you increment the feeds?
So increment of the feeds now depends on, one is like you said, the age of the baby, and second one is how the milk has been digested, right? If continuously you are getting the bilious aspirates, you know that the digestion is not happening, but milk you are not giving only for nutrition, you are giving for the trophic purpose as well, so you would continue the trophic feeds. But increments only if the bilious aspirate stops or abdominal distension doesn't appear. And typically anywhere between 20 to 30 ml per kilo per day you would increase. I mean, for me, for years now, I've put up a simple schedule that whatever the weight of the baby, a particular amount calculated on the basis of this 20 to 30 ml per kilo, that is as a standard we are following.
Would you like to add anything?
I will look at, we haven't spoken, but has a baby passed meconium in the last 3 days? That's
Yes.
important,
Yes,
because
yes,
if the
baby
baby
has
has not passed meconium, because preterm babies can take longer to open the bowels, and if the baby has not passed meconium and there's a plug, the baby can have abdominal distension and a bit of bilious aspirate. Anybody uses some suppositories to just help out if the baby has not passed
Stimulation itself
meconium?
is enough. And other important, sorry, I missed to point it out when I was talking about it, is I hear this from my colleagues or even, junior colleagues as well, but nobody listens to the bowel sounds.
Bowel sounds are present.
Yeah, that information is generally not
Yes,
available, people
yes.
don't listen. And again, if you ask 10 people, people have lost the skill of listening to the bowel sounds.
Absolutely.
They can't even
Agree
make
with
out
you.
what is the bowel sounds, right?
Yes, yes.
So I think let's stick to that, and if the bowel sounds are there, that means
Yes.
the gut is nicely acting, and I wouldn't worry to increase.
Good. So moving on, on day 7, baby is...
I would just like to add, Dr.
Yeah.
Srinath,
Yeah.
a few things. Like you said, clinical examination, again, abdomen is soft. Even if the baby doesn't pass stools, we use glycerine syringing in these small babies, which help them to establish feeds earlier. Other thing is the blood gas. This baby is ventilated. Unexplained acidosis for me is always a red flag. And in these babies, that may be a sign of a perf, which is not very evident. SIP, spontaneous intestinal perforation, is an entity in these 28, 26 weeker we should be worried about. So I would look at acidosis very closely.
Metabolic acidosis.
Metabolic acidosis.
And lactate.
Yeah, those things is something I would monitor and then take a call. We have something called as the ADEPT protocol, the same ADEPT study which you talked about. We have a protocol on how feed should be increased. It's a little slower than we would like, but we have found that it helps us in achieving consistently full feeds a little earlier than when we say, okay, let me go up, the baby is doing well, and then we have to take a few steps backwards. So we are continuing to feed slowly these babies as per the ADEPT protocol. The challenge here is to make sure that the mother's milk production is far exceeding what the baby is taking, because later on the baby will need it.
Okay. Right? So moving on, the baby is extubated to NIPPV, and there is a small PDA which is not hemodynamically significant, and baby is off inotropes, and there is no sepsis, but there is feed intolerance is lingering on, as we probably expect from the history. So this question is to both of you. So what strategies do you use to feed this baby? We know that baby has feed intolerance and is likely to have. So what strategies do you use?
So my first strategy is the more you search for feed intolerance, the more you will find. And therefore, the first thing is do not aspirate, do not do routine pre-feed aspirate.
Correct.
And that's, we also had a lot of difficulty in convincing our nurses. So we did an MSc study with this, a randomized control trial, and when we did this, we reached time to full feeds was 3 days lower. And we just started monitoring abdominal circumference and going by that. Now the recommendation by National Neonatologists Forum, don't do either. Only if baby is vomiting, has obvious distension, then you start seeing all this. So if you're going to be doing pre-feed aspirates, you'll find your feed intolerance. And therefore, that's the first thing. So once you don't have that, still these babies have a very, the gut has its own mind. Yeah. And every time you try to feed and escalate, the baby has issues. So we need to be slow but persistent, and we should not be worried about green aspirates, bilious aspirates, only if it is bloody. Or if it is obviously the baby has vomiting or signs and bowel sounds also play a role, then we need to be slow. Otherwise, persistently try to improve your volume of feeds, and we go up by around 30 ml per kg. Second thing is it should be mother's own milk. Try to do that, because that again has shown time to full feeds is faster with mother's own milk. And we do other things too, because NEC is not only about gut hypoxia. NEC is a multifactorial thing, and the big issue we have is infections. We have to protect this baby from infection, so we use probiotics. That's a very controversial topic, but we in our unit and even WHO this time has recommended probiotics for less than 32 weeks, because NEC, sepsis and mortality are all reduced. So any baby on any amount of feeds in our unit less than 32 weeks is already on probiotics twice a day.
Which probiotic do you use?
We use Darolac, I think.
Darolac.
That's the only one which is there. Yeah, we use Darolac. We did a study actually for feed intolerance. It was Dr. Shashidar's thesis, but it did not show a difference for feed intolerance, but for NEC, probiotics is known to reduce.
See, neonatal practice has been evolving over the last couple of decades. Actually, there are a lot of practice which we were doing before and we are not doing anymore. But most of us seem to agree. For example, everybody agrees for non-invasive ventilation. But when it comes to feeding and aspirating, but there is no much consensus. What do you, we heard Dr. Suman, so what do you think about aspirating and seeing how frequently do you aspirate?
Same, don't aspirate.
Don't aspirate?
Yeah.
Okay.
Don't aspirate. We stopped aspirating. In fact, for term babies, I tell them not to do the lavages for the vomiting babies. It's going to settle. It's going to settle, and it has no value at all.
Japan is one country we can look up to where they don't aspirate at all.
Yeah.
Okay.
Going further from what Dr. Suman said, I will tell if you feel that there is abdominal distension and things are not going as per. We don't stop the feeds. We don't stop the feeds. We maybe reduce it a little bit, but we don't stop and start. That takes us back whole way along. And we had to go from zero again to restart the feeds. So we never stop the feeds unless there's a bang door evidence that yes, there is an infection and we need to do that.
And do you use
how many of you are there? Yeah. So it's one thing we have to remember, that all of us have our own opinions and stuff. And in a team, it becomes sometimes difficult to follow exactly one path. As long as overall you are not deviating, in that standard deviation, these are all not going to change the outcome.
So just one question, do you use any
Add that. I mean, see, we all understand less is more in newborn care.
Yes.
But it's so difficult to implement that, especially with the newer, like our students and all. Every night you would have escalated feeds, morning you come and see, babies, it stopped. You would have extubated to non-invasive, baby would be intubated in the morning. So these are challenges when you're a large team, especially if people are on the learning curve.
Do you use prokinetics for these kind of babies?
So prokinetics definitely have a role, not in this baby, because the main one is erythromycin, but they are studied typically above 32, some above 30 weeks. Before that, the receptors itself is not there, it's not going to act on that. But beyond that, you can use erythromycin.
Okay, we'll move on. So day 14, so baby is stable on CPAP, 850 grams now, and on EBM and donor EBM at 180 ml per kg per day of second hourly feeds, tolerating well. So basically questions to Dr. Praveen and Dr. Suman, what strategies would you use to optimize the nutrition for these babies? Would you use any fortifier?
Yeah. Optimize nutrition from the beginning. Again, you tried, right? I mean, basically how much protein you're giving, how many calories you're giving, and whether you are supplementing with vitamins and trace elements, right? We all know that there are challenges in India in terms of what all we can provide. So as much as possible, the optimization will start, I mean, at this stage, of course, if we're talking about it, fortification you would have started much earlier. Again, there is no exact time when you can start, but the earlier the better, but maybe around 120 or 150 ml per kilo when you are reached, you can start fortification. Initially a couple of days with half dilution and then you go to the full dilution. We use HMF, cost effective. I don't see in India the benefit of using MMF personally with that much of cost going for a MMF.
What do you think, Dr. Suman, about fortification in general, and which one do you
For
use?
these small babies, fortification is needed for improved growth. We need growth, and we need to fortify early, but it's a challenge because they have feed intolerance, and somehow we have still not got, though there are studies showing that it doesn't make much of a difference, we are still worried about fortifying these small babies very early. The guideline is you fortify when the baby is around 80 to 100 ml per kg, but we usually, it becomes later because we are so worried about the gut, and the gut is always giving us problems. Now the issue here is nutrition is not only about mother's milk. This is a baby I would like to request obstetricians to support us in kangaroo mother care from the word go. Because if you're talking about, it's not only about feeding, it's about growth. And kangaroo mother care, exclusive breastfeeding, skin to skin, has great benefits in this baby from infection prevention and nutrition. And all of us know the challenge of getting mother's own milk. Even if you have a blood bank, mother's own milk has far superior benefits than any donor human milk. And therefore, investing in the mother, counseling, and this is where we would like more partnership from the obstetricians, because one word from us, one word from you all is equal to 100 words from us. So that is the kind of support. And these mothers are sick. They are with you all. They are not with us, and therefore we need that support. And this is a baby we would have started maybe, for us, our goal in such small babies is by day 3, they should start KMC, and all these other things will flow. MMF, that is, you're talking about mother's milk fortifier, I'm totally against it in India. Because currently the MMF which is provided is only from a commercial human milk fortifier, and that is not following any ethical issues. They are denying people, and in fact now there is a new thing that it is banned, and therefore there's no question of talking about MMF in my unit. It's a bad word in my unit. Okay, so but yes, HMF, mother's own milk, invest in that, and the cost is not worth it. If you have a milk bank like in Vani Vilas, which will go on to produce MMF, yes, it's all for it. Let us give mother's own milk in any form to the baby.
Sure. I've seen your presentation on KMC. Wonderful work you're doing at St. John's. So any contraindications for KMC, especially with umbilical lines, with ventilation and CPAP? I have seen you advocating KMC even for those sick babies actually.
It's not only me. The current 2022 recommendations about kangaroo mother care says that you should start early, and the recommendation is as soon as possible after birth, and we say by 2 hours, irrespective of the gestation or the sickness. The only 3 contraindications which is mentioned there is a baby on mechanical ventilation, a baby on shock, and a baby who will require continuous monitoring like you need to see. So that is what the WHO recommendation is, because the study was done in more than 1,000 grams and on babies on CPAP. But in our unit, even for this baby, the baby would be on it. It's a challenge to do it with an umbilical line, but our nurses are experienced. The umbilical arterial line is our concern. UVC is not our concern. So we are trying to think of how if we can stitch in the UAC, then they are likely to do it more. But the main thing is counseling the family.
Great. So we'll move on. So the baby is stable on CPAP and 950 grams and 21 days. And baby is on both EBM and donor EBM with fortification. And baby started having bilious aspirates, had abdominal distension, and when we did bloods, there is a increased white cell count as well as CRP is increased, and blood gas shows metabolic acidosis and high lactate. And abdominal X-ray, as Praveen said, different people can interpret differently, but it shows thickened bowel loops. And so the question is, Vishwanath, and what would you do in this baby?
Yeah, this at 3 weeks age looks like necrotizing enterocolitis. Now the gestation age is, or the necrotizing enterocolitis, inversely proportional to the gestational age of the baby. So absent reverse end diastolic flow babies tend to have NEC much earlier than those babies don't have the absent end diastolic flow. So normally the NEC develops about 4 to 5 weeks of gestation. So a 26-weeker will develop around 31 weeks. And this is 28 weeks baby who's developing at 3 weeks age. So this looks like necrotizing enterocolitis. We
So it is not, it won't, it will depend on how the progression is, rather than at that point I stick to one line only.
Lakshman, what's your practice about this baby?
I totally agree with Praveen that we would start, like these things happen commonly. And we do a lot of frequent x-rays once this thing happens. And if we don't find any pneumatosis, we find things are settling, then even by around second, third day, we would even start back on feeds. We send stool for occult blood because that's another objective way of looking at it. And if everything is by third day, we will start. But if things pardon?
What antibiotics would you give for this baby?
Antibiotics in my unit is, our first line is single drug amikacin.
I know that.
And we don't use, and we have something called as stopping orders. By 48 hours, if everything is okay, our PGs are told to not write the third dose of antibiotic. If a baby has to earn more antibiotics by showing that there are more problems, which we take stock every 24 to 48 hours.
What would you use for this baby?
This baby would probably get amikacin for 3 days. If the baby settles down by that time, we would stop it.
Okay, fine.
The other important thing is abdominal tenderness. That's a sign I've learned from my pediatric surgeon. If a baby has tenderness, babies cry, but these babies are supposed to be sick. But if you palpate and you find the baby is wincing, there is a problem in the gut. So those are clinical things that we need to look at.
Just one question to all of you. When we suspect about neck, so most of them usually go for a little higher antibiotics. Sometimes meropenem monotherapy, or sometimes meropenem with other antibiotics. Sometimes add metrogel. What is your take on metrogel? Do you really require metrogel along with the meropenem?
No, okay, so first thing is we use amikacin for I don't know, 8 years, 9 years now as a monotherapy, but with a suspected infection. When there's a confirmed infection or when you're worried about a sick child, we use our second line, which is amikacin and piptas, right? Here's amikacin and piptas, right? Here I would have continued like that because I'm suspecting maybe sepsis as well, third week coming in there. So regarding metrogel, look, these are all the old practices which continue. If you are giving meropenem virtually covers gram-positive, gram-negative and anaerobes as well. So there is no need to give that. If I am on piptas and amikacin, in those 2 days, I would still continue that. I wouldn't add metrogel because it doesn't make sense to me how the progression is. I would look at that.
Great. So we'll move on. So day 35, baby is on CPAP. Weight is about third centile, and of course we had a little drop, and baby is on already 200 ml. Okay. So catch up or no catch up, Dr. Suman? What do you think? Do we need a catch-up growth in these babies who are growth restricted?
I would like them to follow their own curve. And whatever you want, these babies have a flattening. EUGR, continued intrauterine, which continues as extrauterine growth restriction, is a common problem. And what I would like to do is to give the best 180, 200 ml per kg of feed, fortify it fully, and whatever growth occurs with that is fine with me. Because you can't go beyond. There's no question of thinking of preterm formula or any such thing just because growth is not good. Because what we need to understand is growth is important, but it's not the only goal here. We have studies which have shown that babies on exclusive mother's milk feeding may have smaller growth, weight, length as compared to other babies on formula, but their IQ is better. So we would optimize nutrition and allow the growth to continue whatever is needed.
Fantastic. Okay, we'll move on. So further course is basically a little uneventful, and we have done regular KMC. Baby actually got discharged without any complications of prematurity, no IVH, no ROP, and Palada feeds established and discharged home and breastfeeds. And this is the parents, and I have taken the permission to produce, and this is on the follow-up. The baby is doing extremely well, normal, no complications, and this is the latest photo that was sent yesterday. So thank you so much. We'll go to the next case discussion. I would like to invite Dr. Deepti.
She's gone for lunch.
Oh, she's gone for lunch. Okay.
I think the second team will
Should
be
we?
the same.
Chitra ma'am? Yes, yes. Okay. So what do we do? What?
It is an NCDH
We thought.
leave you and go. I can get soup for you.
Actually, sir, soup here.
No, they're all there. They're not allowing me to close the panel. They're telling me it is so interesting, we want the second case. This will run fast, because this is a 10 minutes. Got a commitment.
We deliver the baby, give to the nearest.
That's a good one, Malini.
That's not what we want. We want combined counseling. So many
Patient involvement.
Yes.
Okay, so let's go really fast. She's a 28-year-old, gravida 4A3, 3 miscarriages, and this is an IUI conception. Married for 3 years, non-consanguineous couple. Screening was done and that was low risk. She was referred to our unit for NCDA twin pregnancy with a discordance at 23 weeks. And this was her dating scan. This was done 13 weeks, and we see the CRL of the first baby was 67, corresponding to 13 weeks. The other one was 62, and that was 12 weeks and 4 days, and there was a 7% discordancy to start with. Now, at 23 weeks, when she came to us, these were the findings. So the fetus A, these are the biometry and the Doppler. Dopplers was looking fine. The fetus B, the biometry and the Doppler, and there was single umbilical artery also in fetus B, and the Doppler was looking fine. The discordancy at this point at 23 weeks was 13%. So how will you counsel the patient? Dr. Lata, madam.
Amniotic fluid volume in both sacks normal.
Both sacks are normal.
Discordancy of 13% is nothing unexpected in monochorionic twins. So I would say we will have to continue with two weekly scans, but I hope this lady would have been counseled prior regarding the monochorionic pregnancy itself. That are, the chances of TTTS, single FGR, TAPS, sequence, etc. So all these should have been counseled, and also maternal complications of preeclampsia, increases of preeclampsia, diabetes, and also preterm labor. All these have to be counseled probably right after first trimester's scan. So I would continue with 2 weekly scans with the background information on board.
So,
thank you.
Yes. And Dr. Chitra, madam, when do you want to call her back?
Yeah, 2 weeks, once in 2 weeks, because as of now, the second baby has not gone into an IUGR. It is still only the discrepancy is there. So all monochorionic, we do a 2 weekly monitoring.
That's right. So that's what the SWOG says, and this is the protocol followed by the SWOG. All monochorionic pregnancies must be followed every 2 weeks, and every 2 weeks we see the growth, the biometry, and the Dopplers, mainly the umbilical artery PI, the MCA PSB, and we follow them every 2 weekly if there is no other issue. And that's what we have done. We have explained about the monochorionicity and the inherent issues, and we had reviewed after 2 weeks. And now at 24 weeks and 6 days, this was the finding, and the discordancy was 22%, and this is what we see. So, Dr. Chitra, madam, please comment on this picture.
Yeah, the fetus B is going into asymmetric FGR now, and the Dopplers are still in the forward flow. Middle cerebral points, okay, no evidence of anemia. Okay. But Dopplers are fine.
So what we see right now is an estimated fetal weight of less than 10 centile and abdominal circumference of less than 10 centile. As per definition, the discordance of more than 25% is required, but because of these two contributory parameters being enough to diagnose SFGR, this was called SFGR, and the umbilical artery was showing a forward flow. So it was a type 1 SFGR, and we called her back after a week. Dr. Sushila, madam, is your management going to differ at this point, and do you want to involve the neonatologist at this point?
20?
She's 24 weeks now. 24 plus 6.
No, this is expected of an MCDA twins. And yes, unlike, I would say that it depends upon the unit, like I said. It also depends upon, what kind of setup you are in and how confident the neonatal team will be able to take. Because this kind of a problem is expected with MCTA twins. So I would probably steroid at this stage, 24 weeks, because we don't know how far this will go. I would probably steroid, keep them in the loop, may not keep them in the loop, but then that is what I would do. Anything else?
I wouldn't agree to steroid her at the moment because I want optimization of steroid, administration of steroids. So I wouldn't steroid her. It might still give us some more time. So I would like to reassess the Dopplers in a week's time. In this case.
So we had not
unlikely
steroided
that
her.
it is TTTS. I mean, because it's gestation.
the LICA was
age
normal
is
in all the
24
cases.
Plus. Yeah. And AFI is normal. So whether the TAP sequence, but she hasn't had any invasive
NCPSV
procedure
of both
done
the babies was
before,
within normal limits,
so
there
it's
was no TAPs.
unlikely. So other two causes of discrepancy, growth discordancy, weight discordancy should be kept in mind.
So there was no fetal anemia, so no
There was no anemia
That's why,
polycythemia.
MCA-PSV was also important.
Yeah. So we had seen the MCA-PSV at this point, and one in the first baby it was 1 mom, the other one was around 0.99. So there was no difference, and there was no TAPs at this point. Now we called her after a week. At 25 weeks and 6 days, we repeated the Dopplers, and the Dopplers were looking fine, and we called her after 10 days. At 27 weeks, these are the graphs of the Dopplers. Here again, the picture was the same, and we called her after 10 days. And now at 29 weeks, this was the picture. There was a discordancy of 34%, but the Dopplers were remaining normal. So it was an SIUGR type 1. So how will you manage, Dr. Malini ma'am?
Now this is type 1 SUGR. So definitely it should be followed up with the Doppler flow velocimetry. Yeah.
Normal.
Yeah. So there is a weight discordancy which is fitting into the FGR thing. Yeah, it's more than 25% now. So the baby should be followed up with the Doppler flow velocimetry.
Yes. Dr. Chitra madam, do you have any change in opinion, or do you just
No,
follow
stay managed.
After week. Yes.
Yeah.
So one more thing is, this will be a expectant line of management because 90% of the fetus will fare well.
So that's what the studies say. In type 1 SFGR, we expect a good perinatal outcome. So weekly sonographic and Doppler surveillance is what is recommended, and in all type 1 SFGR cases, because disease progression occurs in only up to 25%, and elective delivery between 34 to 36 weeks is what is recommended by the guidelines. So Dr. Praveen, I would want to get your opinion on if you want to counsel at this point, and what will be your counseling.
Sorry, the decision was to continue screening the pregnancy, I suppose. Okay.
So if we had sent to you at this
correct.
point at 34% discordancy at 29 weeks, what will be the counseling from the neonatologist perspective?
So obviously we'll be discussing about what if they were to deliver, and what are the preparations they would need to do, and what are the expected course of action or the course of problems that the babies may have at the time of the delivery or after the delivery, like that. But majority of the times we encourage them to, as we discussed before, continue as long as possible to support the gynecologist in continuing the pregnancy. And the other preparations would be about, like, we would talk about steroids, we would talk about breastfeeding, and the financial preparation as well that they need to do, family support they would need if they were to deliver. I think we may actually ask them to visit the ICU or, to see, while reassuring to them that the babies, smaller babies do well, and that's the aim of it, not to scare them. So yeah, this kind of a preparation is what we do. Some kind of an agreement in terms of if they were to deliver, what sort of a resuscitation, what they may expect the team to come and do. So those details is what we
So
would give.
do you prefer having an antenatal consult at this point, or would you prefer a postnatal consult?
So it's always we prefer antenatal. The reason being, after delivery, suddenly these new people, 3-4 people are coming in and they have done something on your baby and coming and telling you what has happened is never a good sign. And there are many things that we would have to communicate to them after the delivery. So it's better if there is some relationship with the parents before. Even a larger family itself, much preferable, because they are the ones who come at that point of time with a lot of queries. So definitely we prefer.
Would prefer to do a combined counseling, because we have to talk the same language. Or they just come back and forth and keep saying something which has not been said many times. So I think it is important that we do a combined counseling, and also probably a video recorded counseling, and also document each counseling session and sign, as perinatal consultants. That I think that would go a long way, medico-legally also. So,
Fully agree. I think a combined consultation will make a lot of difference, because not just in this case, in any case that needs imminent delivery, neonatal, any such case, a combined consultation, because it's not just simply handing over. It is.
I think timing of delivery, I think we should have more and more coordinated, what can I say, management, because timing of delivery, and also when we plan steroids, and whether the unit is ready to take this baby. I mean, there are beds or cots, whether we should postpone it by a day or two, not for our own sake, but I mean, whether there is a room for it. All these, I think we should keep discussing every day. I think whatever high-risk cases, especially the preterm cases, it should be on their board also, who are all admitted, and what plan is sort of being discussed. I think
that is important. What we have. We have one WhatsApp group as perinatal emergency group. We have any high risk case which we come across, we put it across, say that this baby will come. Then immediately neonatologists will have there. So that group is one of the most active group, because I think everybody very difficult to meet each other in our daily schedule, but at least we know what's going on and what can expect.
Kept in the loop, So what is the role of steroids in Maxel? Do you want to steroid her at this point, or 30 weeks?
I think
29 weeks with a 34% discordance.
Type 1. I think I would wait for it to become absent, and then steroid, as Dr. Suman also agrees with us. Okay. Max self again. I mean, even in an emergency situation, I don't think we should jeopardize the administration of or the benefits of Max self even. Whatever, whenever, even if it is an emergency, please give it for whatever benefit. Okay. At least 4 hours prior to is ideal.
Now, this situation is quite challenging, because you have to weigh the risk of prematurity against stillbirths, right?
Yes.
Because there are twin, like 2 babies, and it is MCDA twin. So we don't want to have at any cost stillbirth, right? So,
but then right now, because the
baby will be affected.
But that is where precisely Dopplers come into play. Okay, it gives us a lot of confidence that we can bide some time.
If you plan to deliver, give steroids. If you plan to be conservative, I don't think steroids is needed, because you yourself have shown there that the progression is less. Because steroids, the best time that we have found, you all know that the new recommendations on steroids has come out last year. I was part of the action trial, and the best time that we have found is in the first week. So if it is going to be beyond that, then it's not all that good, and there is absolutely no doubt that the brain of the baby gets affected by multiple courses. And a baby who is born term after having received steroids has long-term implications. So we need to give steroids if you're planning to deliver this baby before 34 weeks. Even a late preterm, though I know a lot of obstetricians use it, we are not for steroids in the late preterm period.
Excellent.
Until when you would recommend
Some
steroids?
of the pediatricians say even one single dose it will make difference up to 36 weeks. I really don't know.
So that's why it's a controversial area. Huh?
Recently,
Because of demyelination and things like that. Okay.
Okay.
But do you agree any dose of steroid is better than no dose of steroid? Even if you had to deliver this baby tomorrow, you give a dose of steroid now, and in the next 12 hours, if it is feasible, give a second dose of steroid.
Supposing, I'm just asking this, just this kind of a situation where I feel this baby is might need delivery, but we don't know with Dopplers, it can change. But then, I feel it might need a delivery, and then I give steroids, but it progresses well. And then supposing it reaches something like 30 weeks, is there a role for rescue steroids here?
Yeah. It's a single dose is given, not
Yeah.
a course.
So that is definitely a possibility. That's what I got.
So we called after a week. So at 30 weeks, it was the same picture. Dopplers were maintaining, but we were a little jittery, so we called her in 3 days. At 30 weeks and 5 days, this was the Doppler finding. And we saw the smaller baby had a high resistance flow in the ductus venosus. Dr. Chitra, madam, does it change the management?
Yeah, it does change. Now the severity has increased. I think you should plan for delivery.
What are the false positive rates with DVPI? I have seen false positives with DVPI.
It is.
So jumping and see, that is the only decision maker in this thing. So, yeah.
No, for that
what is the
matter,
false positive?
for any Doppler, we don't go only by one reading.
Yeah, you
And
repeat
ductus
it and
venosus
see.
though is respiration dependent.
Yes.
So when the baby is inspiring, again the changes will be there. But whenever there is a finding, we do multiple times. Even make the patient wait for some time, come back, redo. And only when it is, we are
Consistently
reproducible,
there.
only we call it as, we put it in the report.
Sure. I mean,
Yeah, you have to make sure.
All Dopplers for that
because it
matter
is-
are dynamic.
Yeah.
So now that we have a change in the DV Doppler, and that itself is an independent predictor of risk of demise of the smaller or the larger twin, and as per Asma Khalil classification of SIUGR, it falls under stage 3, and it would recommend intervention. It was stage 3 and we planned for delivery. So my question to Dr. Vishnath, sir.
I might still wait. I haven't administered, if I haven't administered steroids.
We plan after a course of steroids.
Yeah. No. I mean, in case, because I was not for administering steroids. So, because it has suddenly jumped from stage 1 to stage 3. So, I might still wait for steroids, do a CTG probably 12 hours later, and then convince myself that the baby is all right and still wait for steroids. Just
planning for
delivery is fine. Yes. Yeah. Steroid, I might wait for it. Yeah. And the other thing is, I just wanted to ask the neonatologist if that is okay. Steroids, if because of the paucity of time, that is, we can't wait for another 48 to 72 hours. Do you think giving it 12 hourly would make it better? So that you would have had the last dose 24 hours prior to?
Generally, it is given 24 hours, but dexamethasone can be given every 6 hours, in 6 hourly for 4 doses.
True.
Depends on what steroid you're using.
Yeah, because
No.
the betamethasone.
What I'm asking you is the full dose. If should it be, if it's going to be completed within
12
24
hours.
hours, does it make a difference?
I mean, I don't think it is very
Yeah.
There's no studies to support giving the steroid betamethasone in 12 hours, so none of the neonatologists will actually pitch in and say, please do that. Dex 6 hourly is recommended, so that possibly can.
Another thing is the kind of steroid that we have. The steroid that we have is a single salt steroid. It is not a betamethasone phosphate acetate. So it works only for 12 hours.
Absolutely.
It works only for 12 hours, and therefore whether we are giving betamethasone or whether we are giving dexamethasone, it has to be given 12 hourly only. And you will need to wait that
No, sorry. Sorry. Let's not confuse the issue.
That's what I'm saying.
Betamethasone is given every 24 hours.
The betamethasone that we are having that is available in the market is a short-acting betamethasone.
That's why it may not be adequate.
So this thing in Indian setup is different, and we need to recognize that. The recommendations is Dexa or Beta, but if you look at essential drug list and all, dexamethasone is the cheaper one, and it is the one which is recommended. So I think we should consider moving on to Dexa, because there was a time when we used to talk about Beta being less, better for the brain, but that doesn't hold good. The main issue, I think, Dr. Sushila Rani, what you're talking about is everywhere else they are using betamethasone acetate phosphate, where the acetate has a longer action. We use only phosphate, and that has a 12-hourly action. So at least in our unit, our protocol is to use betamethasone 12-hourly routinely for everyone. And we complete our protocol within 24 hours.
So what would be the dosage like when you are giving 12 hours?
12 milligrams 12-hourly.
12 milligrams.
Yeah, milligram. No, but then we have all changed to Dexa for that
so
reason.
So far we haven't had problems. We have given it 24 hours apart for probably decades. But
you're not doing justice to your patients, Lata.
When we know that it is not.
We have had very good outcomes.
That is the neonatologist.
Yeah.
So the difficulties in managing these babies is the number of hands and the number of machines we have free at that time. We have two preterm babies. One is an extremely small baby who will need a lot of support, and the other baby is slightly bigger, if I am correct, 1.3 kg, but they are both small. So the number of hands, experienced hands to manage the preterm, and somebody to overarchingly see what is happening to these babies at birth and subsequently in the NICU. So these are the main things at the time of delivery. We need to establish that we are not lacking the number of hands at the time of delivery. There may be a chance that there is an extra pair of hands, but that is welcome, but we should not have less number of hands.
Hello. Yes, I thank Dr. Sushila Rani, Dr. Lata Venkatrama and Dr. Malini. I know their babies are all waiting and they are ready to go to deliver them. So I request Dr. Anu to hand over mementos to our the Trinity. Huh? No. You have a lot. He has you in the loop now.
I feel very embarrassed to.
No. If you are willing to wait, you can take the mementos and wait. I don't mind, because since you had some waiting case, you are worried.
No, somebody is waiting.
Oh, somebody is waiting. Okay. I thought it was a fetal.
No. I finished and came.
So you would like to wait? Then we'll give it together.
Another 10 minutes, is it?
Within 10 minutes will be over.
Okay. I mean, we don't want to.
Okay. Fine. Now decision has been made to deliver. Okay, so we'll go fast. So we got these two twins. Actually, in fact, when Dr. Ritu called me, we got a MCDA twins. One is 700, another 1,300. The first thought which came to my mind is, 20 twin transfusion. I think we are end up with a lot of trouble. However, the beautifully managed by both our fetal medicine as well as the obstetric team. Just to tell you, there is no intrauterine transfusion in these babies. Fantastic. And the baby is born by emergency section, good UPGARs, reasonable UPGARs, and delivery room CPAP was initiated and transferred to NICU. One is 700 grams less than 3rd centile and 1.3 kilos about 25th centile, and stable on CPAP, requiring about 40% oxygen. So gave first dose of surfactant and compensatory respirators dose in the gas. We had umbilical lines given as a set-in. Good BP, started on TPN. So first question is, so again, how would you counsel? We'll skip that. So what outcomes would you give for these, because we have got two different weights. So one is a small IUGR baby, another one is a well-grown baby. So what would you give the outcome in these cases?
My difference in counseling is only about logistics. You need more people, you need people to do KMC, you need more resources, cost, and your bigger twin will have to wait for the smaller twin to go home. Because all three of you all will go home together. That's the only difference in my counseling. And yes, the smaller one could have more problems, but we will deal with it.
It would be the same even if the both are FGR.
Yes, it would be the same. But cost of care may be higher.
Higher.
That's all.
Perfect.
Everything times 2.
Yes, that's right. So again,
Only for scan they don't pay 2 times. Everything outside is 2. But for twins we can't charge twice.
So as we discussed, we definitely don't wait to start feeds. But would you have a different strategy for each twin? Given that
No, actually we will start the feeds and progress equally on both the babies. But the volume of feeds is going to be different. And we are going to keep a much closer watch on the smaller twin than the bigger twin. If had it been twin-to-twin transfusion syndrome, then the situation, it is not. But then we have to keep monitoring both of them very closely because the bigger twin also going to be having a lot of problems. Any contraindications?
I have a different strategy. My bigger twin is going to be on full feeds from the word go. No need of IV fluids and anything. He's 30-weeker plus, right? And then the smaller twin would get, as per the FGA protocol, abnormal Doppler and this. So totally different.
Fair enough. Agreed. So the bigger twin will progress faster. The smaller twin, we have to take that in a much different
on
way.
average, how many days does it take to get full feeds in your unit, Dr. Suman?
The smaller one?
For the smaller one and bigger one?
The bigger one is on full feeds on day 1.
Day 1?
Yeah, full enteral feeds, unless they run into any problems. The smaller one is the 700 grammer.
Donor milk? Because
we use mother's milk, donor milk. We even use 5% dextrose enterally because we feel that's better than giving it parenterally.
Really?
Yeah.
Okay.
So
you don't give IV fluids at all?
For this, any baby more than 1,200 grams, more than 30 weeker, unless they are sick, they are like on inotropes, ventilated, we start with full enteral feeds. Mother's milk, small amount. We don't have a milk bank yet. Donor milk, and they manage with donor milk because these babies are small. And later on, if we have issues, we use 5% dextrose.
There is a milk bank in Vanevilas Hospital. Are you utilizing?
No, we are not yet approached them.
Okay. Fine. So on day 3, babies are stable. Gases are stable. BP is normal. Tolerating trophic feeds well. Abdomen is soft, no tender, no IVH in this thing. So the question is, how fast would you go on the feeds? Probably it answers the question. So we'll skip that. Increment feeds these baby. Okay. So day 5 comes to there. Now the baby, smaller baby has a heart murmur. But the mean BP is normal. There's no white pulse pressure. But PDA shows about 2 millimeter PDA and LA ratio about 1.16, and then the pulsatile pattern, the Dopplers. Cardiologist report HSPDA. And what would you do? Would you treat this PDA? Given that there is a baby is having is a growth restricted baby. And
why I should treat?
Okay.
So
I'm asking you.
Just because we find things, or we need to know the natural course of the problems, right? I mean, you have heard a murmur, fantastic. Would I do echo? I'm not sure. I mean, when I was training or when I was younger, yes, definitely. Jumping on to learn or whatever we used to do, but now I wouldn't be too excited. For me, clinically there has to be a problem along with the murmur. That is tachycardia. If it is not there, that's the biggest thing for me, that look, this baby is not worried. Repeated apneas happening, then again I'm worried, right? Or let us say excessive weight gain or not gaining weight. So if none of these are present, unlikely that PDA is causing any problem. So yes, if you want to rule out any other structural problems in the heart, echo might help, because you may assume PDA and it may be something else. But again, that's where also we lost the identifying, where the murmur is, what sort of a murmur, what could be the most common cause of that particular murmur. So in this case, I'm not worried. Echo 2 millimeters and all, like we all have done it at different points, different sizes, you can pick it up. So I wouldn't treat this. I would just continue nutrition.
So when would you treat a PDA, Dr. Suman?
in a teaching institute, I think we are treating PDAs more often. So we had this issue that once echo came in on board, our PDA treatment went up. In this small baby, my big concern is pulmonary hemorrhage. Intrauterine hypoxia, particularly in the first 3 days. Day 5, I'm a little more comfortable. So we start, if the baby is 30 weeks, only if they have symptoms, we would get an echo done. And here, murmur for me is also a symptom. I mean, at least an indication for echo, but if they have other clinical symptoms plus other echo findings, here you have only mentioned PDA, left atrium aortic ratio. We have a criteria of 6 criteria and 4 of them needs to be satisfied for us to do this. So this is more based on echo with symptoms rather than treating only based on one value in echo.
Wish you any difference?
I agree with Praveen practically because we see a lot of echoes and the echo must be done if there is a murmur. Just to rule out any other thing, we anticipate it's going to be a duct, but it could be duct plus something else or minus duct but plus something else. That we need to rule out, structural hearts. But it's just a PDA and all that baby is stable, as Praveen said, no tachycardia and the baby is feeding well, I'll probably leave the baby alone.
How many PDAs you have treated in the last 5 years?
I would possibly count in my one hand. No, we haven't treated a lot of PDAs at all. We've seen PDAs, but then also it depends on how you manage the initial part, not giving extra fluids and all that things. But treating PDAs, hardly 5 at the max in the last
How about you, Praveen?
7-8 years. I have last 4 years information. If you ask me, I have not treated a single one. Then you have to immediately ask me how much time do I spend in the NICU. Very less. My colleagues would have treated with paracetamol in between.
Okay.
So that's the reality.
Questions may be asked. Paracetamol is relatively harmless. Would it harm if you give paracetamol? What do you think?
So that's why I'm saying, right? I mean, you can have protocol, but the people on the ground with the baby, when they're seeing that, they get worried and they treat more often, right? And I always discuss with them, debate with them, but I leave it at that. My point is, if you really are seriously concerned about the PDA, probably you treat it appropriately, right? Don't use half-hearted measures or whatever. And make sure that the other things, anemia, platelets are normal. If your platelets are not normal, it's not going to close. Anyway, it's a clot which has to form there, right? So look at the overall, not just looking at the echo and then trying to give some medicine.
Okay, fine. Okay, we'll move on. If PDA opens up later on, for example, after 2 weeks again, after treating initially, would you do anything different? What
is the PDA causing? This is the same question I ask. Why are you worried about the PDA? Unless that PDA is leading to some problem, right? Again, heart rate is normal. I don't believe that the PDA will cause a problem.
In fact, at that time, the PDA is going to be less of a problem because the baby has matured more and baby has gained weight as well. So it's going to be less of a problem.
And the pulmonary hemorrhage as well, majority of the times it's a failure which causes pulmonary edema, and that's a pulmonary hemorrhagic edema. So unless you have a failure, you're not going to have that. So those days of when you give surfactant, suddenly reducing the pulmonary pressures and then leading to the hemorrhage is extremely low now.
So feeds wise, they have done fantastically well, especially, of course, we didn't go into full feeds as you do in Dr. Suman in the day 1. So, but for both of them actually reached full feeds by 9 days and crossed the birth weight by 11, 12 days. That was reasonably good and no hiccups there. So, what strategies to feed this baby? I think we have already discussed about it. We'll skip that. Okay. So, this will also probably. When would you stop caffeine? That's one thing I want to ask you. When would you stop caffeine for these babies?
Again, you started with a purpose. If you remember that purpose, that's good. One is apnea, kind of a prophylaxis for that, and second one neurodevelopmental, right? So typically the stable babies, standard what we set it is, 34 weeks and beyond generally don't continue if you don't have any issues. But many times we end up stopping before that as well. If they are off CPAP, there is no oxygen requirement, no apneas for a week or something, so you stop them and monitor them. So 34 weeks is generally is what picked up, but many of them might go home by 33 weeks. So if they are ready, so you tend to stop earlier.
Okay. But if the baby is still on respiratory support, you would continue at
Yeah.
34 weeks.
Sure, I would.
There have been instances where I have continued at 36 weeks also because the baby is needing support. And all that, but generally agree with what Praveen says.
Dr. Suman, when would you screen this baby for ROP and how important it is to screen and what outcomes would you?
Latest by 3 weeks. Our unit protocol is latest by 3 weeks. If the baby is less than 28, we screen by 2 weeks, though it may not be successful. And IUGR is a risk factor for worsening ROP. We need to remember that. And therefore, even our bigger babies, 2 kgs and all, if they are small in weight, they need to be screened for ROP because ROP is a real problem that we need to look at.
So these growth restricted babies that are higher risk.
Higher risk. So between the twins, the risk for ROP is with the smaller one.
Okay, great. So further course, basically both one baby is off CPAP by day 16, the smaller one is off by day 30. Start regular KMC, no IVH, no ROP, and followed on breastfeeds and discharge home on breastfeeds. And what would your discharge plan for these babies, given that the significant growth, weight difference is there? And also parents are worried about the smaller weight of the twin as they keep going. So how would we counsel them about the catch-up growth and not to actually chase up the growth? That is one of the things in the follow-ups usually.
As Dr. Suman said, there's nothing you can do to push this baby to grow higher than what the potential is. So you give the appropriate nutrition to the baby and allow the baby to grow at their own appropriate rates. You can't make the baby grow at a different rate than what the baby is inclined to. So that is what I would agree with, and there's no reason we can give extra powder or something to make this babies grow. Discharge plans and all, yeah, we call them in a couple of weeks time, see that they are actually gone home and they don't have any teething problems. If there are teething problems, you come early, get them sorted out. And if there are no teething problems, every 2 to 4 weeks, depending on what concerns they have, we follow them up, but not generally within a month's time. Generally about 4 to 6 weeks for the time of vaccination, I do all full assessment from head to toe and take a proper history. Early you pick up, the earlier you can intervene as well.
Okay.
Yeah, the father has taken charge of the younger one.
I need to add
Smaller
something,
Yeah.
if you allow me,
Please,
right?
please.
Because obstetricians are there.
Yeah.
Soumya is missing here. One request I have, because obstetricians are there, actual neonatologist role is almost very minimal. It's more of the other team members, like starting with what are the things that we need for the best outcomes. Good antenatal care and antenatal peripartum care as well, which includes antenatal steroids, maybe Maxelf based on gestation age, but delayed cord clamping, please. Well, continue monitoring the data. I'm saying that's the QI which was supposed to be started. Can we start that? As much as possible, 100% delayed cord clamping, or at least for 1 minute.
Is sort of not
So, breathes well, though their paper suggested that even asphyxiated babies as well might benefit, but not at this point of time. The babies who are breathing, no, you need a flat surface. There's a separate equipments are available, which is not available. So, eligible babies, 100%, let me put it that way. And then as soon as possible, the colostrum and milk, again, we are not doing it. Obstetrician support and labor ward nurses support would help. Next, nursing staff in the NICU for reducing the infections. If we can achieve that through good infection control practices and KMC, if we can implement that, again, none of us are getting involved really hands dirty there, right? And stepping back a little before starting antibiotics or taking it off as soon as possible. Then all these problems of whether we increase by 20 ml or 30 ml may not make a difference, because ultimately you are worried about infection with the central lines and all, which you would have reduced, and confidently you are getting the mother's milk, you will be able to increase that, so your NEC rates are low, your involvement is less, so less interventions for the baby and better outcomes. So that's where it's the teams around us which matter, and that's where the leadership should be focusing on. And we have to thank our obstetricians for giving us a baby with antenatal steroid cover. Hence, literally for 3 years we had 0 NEC. That's thanks to them.
Absolutely, it has made a lot of difference.
Excellent.
Thank you so much for this excellent discussion. So
it's all the summarization. Well done.
The more
I feel we should have a combined decision making, combined counseling that goes a long way, actually. So all these points can be emphasized
in that.
And if we sat together, so that we don't forget and you don't leave us.
I just wanted to mention
what that
antenatal corticosteroids is a part of Lakshya program.
Yes.
So you have a register where how many case of preterm babies, how many received antenatal corticosteroids. They have to answer if they don't give.
What that combined talking to parents also gives them a lot of confidence, because we are at the same playing level and we are talking at the same time, at the same pace and everything else there.
Actually, with antenatal corticosteroids, I think most obstetricians are giving. We are worried about abuse of corticosteroids.
That is also something we should look at.
Repeated doses are being given, and indiscriminately. So that is one thing we are worried about. Anyway,
I would like to make 3 points. One is about the small baby, periviable baby, 25, 26 weeks, because I kept hearing maybe that baby is not viable 26 weeks, and we get a lot of such babies with IVF and all now. I think the time has come for us, if you look at who believes in these babies, the parents are the first to believe. Second is newborn neonatologists, and however I found there's a little bit of hesitancy from the obstetrician side. So I think we need to realize that 25, 26 weekers do well, and we need to give them steroids, because many of them don't give steroids till the baby is around 26, 28 weeks, and some of these 25 weekers miss out. Second, people were asking about the brain. Newborn brain has a lot of plasticity. They have double the number of neurons they need. And taking care of them not only in the antenatal, postnatal, but nurture care is very important. And here I would like you all to go to a YouTube channel of something called Palaki Sisters. You will find an 800 and a 700 gram babies. Palaki Sisters, go and see them. One of the smaller ones had lot of issues till even the question of withdrawal of care. Now, I was remembering them when you gave this case, because this other twin, 1.3 kg, will have a lot of things to help the sibling. And the parent should realize growth will be different in them. They should not compare. Height, weight, everything is going to be a little bit of a problem. Learning disabilities may be an issue subsequently. We need to be open to it, and they need to support and not compare. Not things that we need to discuss immediately, but follow up, early intervention, absolutely essential. And my second thing is, there's an entire series in Lancet called the Small Vulnerable Newborn. Please look at it, and you'll see the biggest interventions are antenatal and not postnatal. Lastly, I would welcome everyone to a similar perinatal meet, which I think all of you all are part of, on 2nd July, which is going to be held at St. John's, called REAP, Recent Advances in Perinatology, with BSOG, St. John's and Neonatology. So that will have an entire day to discuss many such things.
Thank you so much.
Now,
may I ask Dr. Anu to hand over the mementos to our esteemed panelists, obstetrician. Who don't want to get up from the seats. Please sir, wait sir.
Thank you very much.
Non-money will
learned a lot. Learned a lot.
Thank you very much, both of you.
Dr. Lata.
Wonderful. Thank you.
Get on top. Shruti, come.
A fantastic discussion.
ಎಲ್ಲ ಚೆನ್ನಾಗಿತ್ತಲ್ಲ ಸರ್, ತುಂಬ ಚೆನ್ನಾಗಿತ್ತು ಸರ್. ನೈಸ್ ಟು ಸಿ ಯು.
Those nuances can be brought
out only in this. Dr. Malini?
You can wear all events. Allah madam, then put it in a cover. Just give it. Bhadra reverse here. Malini. This is Sushila. Thank you. Thank you. Nice. Chitra. Thank you for making me a part of this.
Just 1 minute.
Dr. Malini?
One minute, I'll just come. Madam, you're that, huh? I'll call upon Dr. Manon Mani to come and felicitate Dr. Suman. Ah, 1 minute, madam. Shruti? Dr. Manon Mani is a Syrian obstetrician from Vimalaya Hospital. Okay. Madam. Dr. Suman. Dr. Suman. Dr.
Yes, thank you. See, Ravi, nice seeing you.
Yes. Look at it. Come. Dr. Tejal, please come. Come.
I will stand here
Yeah.
for someone's sake. For everybody's sake. For everybody's sake. Like this? No, madam was giving.
I would invite Dr. A.G. Babu, senior. Okay. Oh, good.
Thank you.
I would invite Dr. A.G. Babu, senior pediatrician from Vimalaya Hospital, to give a memento to Dr. Praveen Venkatagiri. Praveen Venkatagiri.
Nice listening to both of you. Learned a lot.
Learned a lot. Discussions. Next to Dr. V.P. sir.
ಅವ್ರನ್ನ ನಮ್ಮೆಲ್ಲರಿಗೂ ಕೊಡಕ್ಕೆ ವಿ.ಬಿ. ಸರ್ ಎಲ್ರಿಗೂ ಕೊಡಕ್ಕೆ ಹಿಂಗೆ ದಿಸ್ ಸೈಡ್ ಓಕೆ ಓಕೆ
ಬಾಬು ಸರ್ ನಮ್ಮನ್ನ ಜ್ಞಾಪಕ ಇದೆಯಾ? ಹೆಂಗೆ ಬರೀತಾರೆ
ಭಾಸ್ಕರ್ ಬನ್ನಿ. Okay. Thank you so much. One more. Dr. Vishwanath. How much? Give the... Dr. Deepthi can give. to Dr. Vishnath Kamuji. Now I'll call upon our beloved VB sir to give mementos to our team members. Okay, fine. Come, sir. I would request Dr. VB sir to give memento to our Chitra madam. Thank you. Good, very good. Thanks for coming.
July 2, I want to talk to you.
Sure.
Just have your food. Yeah, sure.
Thank you so much.
Thank you.
This is Dr. Vijay Bhaskaran, our executive director. Our executive director, Dr. Vijay Bhaskaran.
We learned a lot about neurology. It was really early. Yeah, a lot of learning.
It was really amazing. It was good together. Sir, come, sir. Come, sir. Come, sir. Please, you come. You come in the center. We'll take one picture. Come. Soumya. One minute. Bhaskar. I would request mementos to be given to our team members by Dr. VB sir. Mementos. Get the mementos. For the madam. For the madam.
Oh, thank you so much. Let me check. Let me change later.
So, a really wonderful program. So,
Thank you.
To Dr. Deepthi. One new one. Dr. Tejal. Dr. Bhaskar. Well,
nice color.
He's always looking.
Dr. Soumya. Dr. Anu, please come.
Hero of the day.
He's waiting for the solo picture. Once we have all gone off the
So they are giving you white.
Whichever is fine, sir. Because we spread love. So, actually, thank you very much for all of you to spare valuable time, and thank you for all the panelists and all the doctors who have come from far off places, and our referral consultants. And it would not have happened without the support of all the three wings of Ma Kaveri, that is fetal medicine, obs and gynae, and neonatology. And special thanks to our marketing team to really not to leave any stocks unturned. And thanks to our senior management headed by Dr. Vijay Bhaskaran sir, And it has been really wonderful work from all of us, and hopefully we look forward to more such events. Okay, thank you one and all. And least we have some co-sponsors about as well as the Acuity Lab, and also we have got videographer who are telecasting live on YouTube. Thank you so much for that. And come. Monica, Nimisha, Raj, John.
John wants to stay. Hey, Maheshwari and team. Shumitra sister.
That's the bench, yeah.